session. Let me know if anyone has any objections, and feel free to add any non-urgent questions in the chat, and don't forget to state your name when you are speaking so that I can document proper meeting notes, and please mute yourself when you're not speaking. So our SMEs for today's session is Dr. Yang and Balveer. I guess she is not attending this session, Nico and Samantha. So I will ask our SMEs if they can say a quick hello to us.
Hi, it's Connie. I'm one of the respirologists.
Hi, it's Nico. I'm an administrative supervisor. Samantha and Javier will not be attending the meeting today. Samantha wasn't able to because she is covering today.
Okay, thanks. Thanks, Dr. Yang and Nico. Yeah. No problem. So our CST team will introduce when we will come forward to presentation. And purpose of this session is, as you know, we are covering all the respirology clinics, lung clinics in this, asthma and severe asthma, cystic fibrosis, including newborn CF screening, home tracheostomy ventilation clinic, respiratory and sleep clinic. So we'll discuss about pros and cons of merging publications, and then we'll head towards to review the pending workflow and content about referral and triage, then some follow-up items on referral and triage from last sessions. So from the dependencies on co-location perspective are the request list. We have appointment types, reporting, encounters, and label and face sheet printing, document types, referral, follow-up orders. So we'll go in each of this, and we'll discuss how merge application will have, what cons and pros will have on these dependencies. So I will request Jacob to. I will ask him to present from scheduling.
Okay.
Jacob, you're here.
Yep.
Thank you.
Thanks, Zook. So hey, Dr. Yang and Nico. Jacob here. I'm the scheduling application analyst. So just to give you a little bit of the pros and cons versus consolidating locations versus having separate core locations, a lot of the impact does happen around a scheduling and registration perspective and a few others as well. So we will touch on those. So first is the request list. So the cons of merging locations for the request list is going to be the effect it has on the request list by location. The request list by location will populate for every clinic, assuming you guys would consolidate. All of your internal referrals and follow-up orders will flow to the same request list by location. This is a request list that is taught to use by CST. However, we could utilize a workaround, which is the request list by queue. It just won't be as organized and may not be able to use the same full functionality. As you'll see later, we are in the process of getting approval for a more extensive request list, but right now that approval is for request list by location. So to be determined if you will be able to utilize that in the same fashion if you did only have one location.
Sorry, Jacob, can I just clarify, when you say request list, do you mean wait list, or what's a request list?
So a request list is all your future requests that are coming. So either your referrals or your follow-up orders, they will flow to the request list, and the clerk manages that list, and from there can move it to a wait list.
Okay, and
or a triage list. Hi, Dr.
Or a triage list.
Yeah, so this is for your internal referrals, so those electronic orders that your internal providers will write, and the follow-up orders that you and your colleagues will write.
Okay, so sorry, that is unable to utilize request list by location.
So
okay, I'm sure you guys will sort of get into it, like what does it look like if we merge versus not? What does a wait list look like, or something like that?
Mm-hmm. So okay. If we merge you, then the most common request list that we recommend that the staff use is the one that just pulls by location. So as you can imagine, if you have separate locations, then that request list just looks at the requests that are for each distinct location. But if we merge your location, then all those requests will come into one request list. So the clerk will then see requests for all of your different subclinics.
Okay.
In the same request list. So I'm not the best to say if that's a good or bad thing for you all. Only you know what's the most appropriate thing for your clerk to see.
I thought there was this whole thing about that the locations doesn't dictate the wait list. I thought that was the whole thing.
This is the request list, not the wait list. Yeah.
Okay.
So this is just the incoming pipe. So the very first time that a clerk sees requests to do anything at all, whether it's to send it to you for triage or to book or to wait list, this is their intake pipe, basically.
Okay, gotcha. Nico, any comments about that one? Okay, if not, because I'm just sort of thinking like the way that I'm envisioning this work queue monitor is actually that the pipe of information is going to one place anyway. So is there anything else that I'm sort of...
So work queue monitor is the incoming requests from where your faxes would normally come. So that's your external requests. Yeah. And so if those are coming into one place, it would probably make logical sense for your internal referrals as well to come onto one request list, so that you have a clerk who's able to quickly look at your work queue monitor for all your incoming requests from fax, and your request list for all your incoming requests from inside the hospital.
So can I ask though, when somebody like just a provider is saying, you know, I want to refer to asthma clinic versus sleep clinic, is it still possible to build that out in the system as a separate thing? It'll just merge through the back end into one giant request list for the clerks.
That's right, but the clerk can still see on the list what the request was for, whether it was for asthma or sleep or whatever.
Gotcha. Okay, sounds good.
Yeah. And it's in here. I just had a quick question too. So it's sounding like both the request list and the work queue monitor are basically like the to-do list for the clerks. Yeah. And that means multiple clerks would be able to access both of those lists.
That's right, and that's pretty common. So even if you have everything coming into the same list, you can, with your operation, decide that one clerk is handling, you know, asthma and sleep and whatever, and another clerk is handling this other group. You could, and that's also how they kind of cover for each other. Yeah.
And so I guess in terms of just say reporting, so, and maybe this gets into like the wait list. So you have a giant pile of information that sits on this request list, hopefully not for very long. It goes through a triaging process and then gets put into individual wait lists. Is that the right workflow?
Yep, if that's what you would like, then yes. If you would like individual wait lists for each of your subclinics, then we can definitely do that.
Okay, and then, so if I want to know in a year's time how many kids I have waiting on X wait list, that's easy to pull?
Yes.
Okay.
And sorry, just confirm it, we can filter which clinic is looked at, right? Like for waitlist purposes, I can filter out the asthma waitlist, the sleep waitlist, like respiratory waitlist. I can.
Nico, I think we're going to show you this a little bit later, which will help you conceptualize it. If you haven't seen it before, it might be a little hard to understand.
Okay.
But I'll just quickly say the way we configure your wait list is totally customizable by you. If you want to see every one of the respirology patients on the same wait list, so that you can see easily if they're waiting for asthma and CF, then we can do that. If you want to have 10 different wait lists and for the clerk to put the request on the appropriate wait list, we can also do that. But we'll ask you to just go with us for now until we're able to show you a little more in the system.
And so before we move on to that, just further to Connie's question, it's Susan here. In terms of the work queue and request list, I guess we're also able to kind of pull, you know, what the workload or the list is in a report format from those areas?
That can be differentiated based on what the request is. So whether it's a referral to asthma or a referral to CF, we can pull that. It's not as front-facing when it all comes into the same queue. We do have to do an extra step to tease that data out.
So, Kat, can you confirm that the referral orders are able to be built at a different location or at a different level than the location? Like, even if we built one umbrella location, you could still request to the asthma or sleep or...
Yeah, absolutely.
Yes.
our standard build, or? Yep. Okay.
Okay, so.
Okay, so going next to appointment types, this one is not as crucial. There's workarounds for both ways. So right now, having separate locations, each appointment type will be prompted based on the location that the clerk does choose. So in the screenshot, you can see the clerk enters the person's name, and then the appointment location, and then next the appointment type. And dependent on what location is chosen, it will only pull back the appointment types associated to that location. So if all of your locations are consolidated, the clerk will have to filter through all of the appointment types.
So it's just a longer list.
Mm-hmm. And is there a standard set of appointment types, I would imagine, that we're using?
We are copying your existing build.
Oh, and is there opportunity to change that? Because how we've been using appointment types in our existing build is very much based on clinics or populations. It's a lot of workarounds.
Yeah, for sure. We can change that. I think our only standards, as you can see on the screenshot here, is the way we label the Respirology, the follow-up, and the new. And other than that, it's built to suit your needs.
Oh, so you're saying from like respiratory division, we would see neurology follow-up, neurology new. Is that what you're suggesting? Okay.
Generally, yes.
Are you able to make that a bit bigger? I don't know. My old eyes can't see that totally. Thank you.
And then can I clarify? So I think some of the ways that appointment types are used perhaps in other divisions is like, say you have 5 quote unquote clinics under one location, then it's really by appointment type. So it'll be like cardiac function new, cardiac function follow-up, dysautonomia new, dysautonomia follow-up. Is that because like in the system, those are different lengths of times for those appointments or different resources attached? Or is it for like reporting purposes?
It can be all of the above. It can be, so different appointment types can be associated with different resources. You pretty much labeled them all, so all 3 can be changed.
So Nico, can you clarify, because I think we have umpteenth kinds of follow-ups and news, but given that we can no longer have like a clerk book, say a respiratory follow-up, then that automatically books a spirometry, because now as a physician I have to order that test. I suspect we could actually just have completely generic follow-up and new sort of appointment types. But can you just tell me if there's a clinic that doesn't make sense for?
No, if you're the one who can actually book the PFT now or request for it, then I guess that's fine in that case. And we just book follow-up and book a PFT. Is that?
I just want to clarify, hey, it's Kat. When we talk about merging your locations, we're not going to include PF, so this probably isn't the most appropriate screenshot. We want to keep the diagnostics in the separate location. So when we talk about merging your locations, we're talking about your asthma and CF and general resp and sleep study, et cetera.
Yeah, so I don't know how it works, but like, for example, right now in our, say, respiratory location, it used to be built into the system that I wouldn't order a test or whatever. It's on our little piece of paper. So when the clerk books, say, a respiratory new and that patient's over the age of 6, the system automatically books them in for a pulmonary function test and a clinic appointment. I understand this is not the functionality moving forward, though. Correct?
I just want to confirm, because I did. Sorry, it's Nico. I was talking to Jordan and the team. I did want that to get built in where I can book a respiratory follow-up with a PFT. Is that not happening anymore?
Sorry, it's just Brenda here. Are you talking about like through the same appointment? You can by all means absolutely like book 2. It would be 2 different appointments. So if we had like a request list. And if it's the same clerk's booking, you would book your pulmonary function, and then you would book the corresponding follow-up appointment with the respirologist.
So we have to book twice. Is that what I'm understanding?
That's my understanding, yes.
Because then, like, that is going to be, to be honest, that would be such a big of a hassle for the clerk to do so if you're not able to do it at the same time. Just because the time frame for doing that, it does take some time for a clerk to do so. Because right now, as a clerk, if Dr. Yang needs a follow-up with a PFT for a patient, I can do it in one appointment type where it gets me to select a PFT, and and a follow-up instead of doing
So we are trying to figure out the workflow to use those and utilize those protocol appointments. Those protocol appointments where it is the PFT first and then a follow-up appointment or a new appointment, those will be easily accessible for your external referrals. But for right now, we're trying to find out the workflow that you could use that's easiest for the clerks for those internal referrals, because right now the internal referrals are associated to like a respiratory new or respiratory follow-up appointment type. And so we just, after we get the core locations figured out, we're going to dive into that workflow a little bit more.
I guess though maybe what I'm saying is that one of these things influences the other. For example, say in sleep clinic, they don't book any pulmonary function tests.
Right.
So we'd need different appointment types for that clinic versus if we're just talking about a generic follow-up and new, they can just be generic.
This is Kat. I don't think I would recommend a generic because you will lose that information. So then you won't be able to tell how many appointments you had for asthma or for CF or for sleep.
Right.
Okay, so this is the way that we actually keep track of that. So there's sort of like, you can pull data from individual wait lists, that'll tell you wait list data, but if I want to say how many kids we saw in CF clinic or something, that's by appointment type?
Yes, it is. It's very important. Oh, go ahead.
Yeah, it's important on that, but also you have to have that level of detail either in the location or the appointment type. Going generic on both will mean that you won't get the data.
And can I ask too then, in terms of that, because it's more than new and follow-up then, because those are, I'm assuming those are in-person face-to-face versus a new or follow-up could be virtual health or outreach or a telephone call. So would those need to be captured in appointment type as well?
So within the appointment types, there's a field called visit modality, and the visit modality identifies whether or not it's an in-clinic or video or phone call.
Okay, and then how do you pull out the information about what resources were around that appointment? Like some appointments might involve the whole multidisciplinary team versus maybe it's just the doc and nurse. Is that able to be pulled out through the scheduling piece of it and associate to, a new telehealth appointment, for example?
I would assume those are resources, but scheduling team, can you speak to that, please?
Susan, I'm sorry, I'm just a little lost on your question. Could you repeat what you mean?
So what I'm hearing with these appointment types, and I'm just trying to figure this out here, is that we want to be able to pull out the visits that we had. It's going to be associated to appointment types. So if it's a new or a follow-up, we want to be able to say that was a new respiratory or a new asthma that we saw. I also want to make sure we're able to capture, the location, I guess, for lack of a better word, outreach, telephone, and then also that appointment potentially involved more resources than another appointment. So one may involve just the nurse and doc, the other one may have involved, a broader group of resources, disciplines. So I want to make sure that we're kind of carrying that through from this appointment type. Does that make sense? No, okay.
I understand the question, but I mean, I guess part of the thing is also, and I bet different clinics do this differently, is that a lot of our multi-D clinics, we don't book all of those multi-D people as a resource. Like, for example, cystic fibrosis, and maybe somebody can correct me if I'm wrong, I think that's just booked as like a physician visit, and then it's the understanding that the whole team or part of the team sees the patient as decided in the morning huddle. So like, I'm not even sure right now those are all listed as separate resources, and part of the reason I think this is because in asthma clinic, we used to have the asthma nurses as separate resources, and then it created all sorts of problems because sometimes the nurse would decide that day actually they only have time to see X patient and Y patient, but it shows up on the patient's schedule and created a lot of confusion. So we ended up just removing all of the extraneous resources from our appointment types, but I don't know what is done across the site.
Well, it's variable. That's the problem. And I think part of the operational challenge with that is we're not able to easily define what the resources are to see patients. right? Because there's that variability.
Hey, it's Kat, and Dr. Yang's exactly right. It's based on the clinic's needs. So Susan, for an example, in ophthalmology, when the orthoptist is going to participate in the appointment, they have asked us to build a shared, like a two-person appointment type, basically, so that it does capture that both of those resources were part of the appointment, but it does make the booking more complicated. So it's about, would it be worth it? So this is just part of normal scheduling design. It doesn't have anything really to do with merging or not merging your core locations. And if you currently don't book the nurse in that CF example, then we would not be building that unless you specifically want to change something. Susan, if you are interested in capturing workload for someone like that, we can build a power form that the nurse just adds in it how many patients they saw that day or how long it took or whatever. That's how we capture workload for those more frenetic clinics where it's not possible to use appointments to see who's doing what for how long.
Right. Okay.
Yeah.
Can I clarify though, because I think part of the reason we got rid of the resources in the appointment types is it forced you to sort of give an amount of time for that person. And so like, can you actually just build a resource that says for every sort of asthma visit, let's say there's a nurse as a resource, but it doesn't actually put that person into a time schedule?
Unfortunately not, and that's where I would recommend just using a power form to capture how much time was spent.
Yeah, so I mean, I think just Susan, from your perspective or my perspective, that's why this adding resources, it's really hard because clinics don't typically work in a very structured way. And then it's very confusing when the patients were getting itineraries because they expect to see the nurse at 1 and the physician at 2, and it doesn't work that way. And then the patients were really getting quite unhappy about that. So like if there is a different way to capture workload, ideally for me, it's not by appointment types and resources.
Yeah, I mean, I hear what you're saying, Connie. We certainly can get better with some of our areas in clinic flow for sure. And that's part of the issue is trying to get that operational kind of lens on how do we engineer our schedules and flows better. But I hear you totally. So it sounds like there are some ability to do that, like you're saying, through the power form or other ways. So yeah, I guess that it's helpful because I was just trying to understand the appointment types and what we'd have to capture there.
I mean, I guess just because we're designing all of this stuff, nobody sort of mentioned that concept of power forms for allied health sort of workload. If that's something we need to think about in our clinic designs, because that's really most of our clinics are multi-D, then we probably need to hear more about that option.
Sure. Well, it's definitely not the enterprise to capture workload, but if it were an absolute requirement. Kat, like how many clinics have requested that today?
We have one clinic doing that, and the reason why they're doing it is because patients drop in, so it's impossible to schedule them. So we would definitely evaluate if there's any way we can capture it in scheduling, but at some point it becomes not worth it, and the power form becomes the easiest thing to do. So we can follow up with you about that.
Okay.
Okay, flowing to reporting. So reporting will be affected because it will not be as straightforward to just run reports based on locations. We could, if you guys decided to stay with separate locations and you wanted a bigger picture report based on all the locations, we could tie that customizable group of locations to a location group. So that location group or groups, however many groups you need, we can run reports on those. But a workaround to that, if you guys did have one core location, is we'll just instead run reports on appointment types and different resources in case consolidation did happen.
Well, but what about our standard enterprise reports? What happens with them? They're all location based, are they not?
Believe so,
Yeah.
and so it would limit the usefulness of some of those. But so what we would have to do is the reports that we know you're going to use, we will have to evaluate those to see if we need to build you something custom to get more granular. And when we say reports, we mean reports out of Cerner. The data that Cerner sends to your own data analytics that you all use to make your site reports, that data will still work for you if you keep your appointment types specific enough.
Is there a list? Because I think this keeps coming up in design sessions, but I don't think I've ever seen a list. Like, what reports does Cerner generate, just so we can see which ones we would use? Or is it like hundreds of reports?
There's hundreds. Can
Hundreds.
anyone from the scheduling team comment on what you think the most common ones are?
The daily appointment slate.
Yeah.
Daily appointment slate. So, for example, like, is that different than, like, I get a report every day that says what patients I'm seeing in respiratory clinic, and then if I'm seeing patients in asthma clinic, it'll give me a separate list. Is that the daily or is that something different?
I think that's the same thing.
So, for example, if I'm seeing some asthma patients and some respiratory patients or some sleep patients, that just gives me one report of the day. It doesn't actually specify what quote unquote sort of clinic I'm seeing them as, or is that right?
I think that report does show appointment type, but you would have to just look to see which ones they are. But yes, it would be all on one list. You can also call a report a resource, so you could call a report just for yourself. But again, that would show you everything from all of the subclinics. So this is one example of something we can get back to you on probably pretty quickly, because I think out of the hundreds, there's probably only like 5 or less that they use all the time.
Mm-hmm. Yeah, and there's like 4 main categories of reports. It's mainly run off person, resource, location, or request list.
Is there I feel like I'm missing something here. Is there a committee or group that's looking at reporting out of Cerner, and I'm not looped into that, and I don't know if it exists, but that might be helpful.
What do you mean by reporting out of Cerner? So your data analytics, like Ali Reza, would be kind of in charge of what it looks like from a data analytics running reports, and then the other reports that we have in like front end Cerner are the enterprise reports that have sort of been designed based on our enterprise design.
Okay.
So what exactly are you thinking?
Well, I guess I'm thinking like we already have some reports that we pull out from like the daily tasks that Connie's kind of mentioning, but then up to more, broader data. Like I think there was a circulation of some emails around this waitlist report that we have and other things like that. So I'm just wondering where would we reconcile, okay, here's how we're getting reports daily, even some data audits of hanging encounters and things like that. Where are we going to be able to see if we can pull that out of Cerner, the new CST, or not, I guess?
So I think if we do this the same way we did for BC Cancer, which is that your data analytics is responsible for giving us a list.
Okay.
And we satisfy that one of 2 ways. One way is making sure that we just capture the right data in Cerner so that your data analytics can slice and dice it however you need to. So a great example of that is us making sure that the appointment types are specific or basically meet your needs, because that's a really critical piece of information that your data analytics will leverage to make your reports. And then the second option is reports like pre-configured or custom reports that are generated from Cerner by Cerner users as a normal course of them doing their work. So as you say, a daily audit of hanging encounters is something that I would, and Colette, you should jump in now. But
well, that's we do have a registration work list to help deal with the hanging encounters. They're just, clerks are not generally great at it. So we've like CNW's probably had to create extra reports on it on top of, and I'm pretty sure we do have that as well. Because usually Karen David's RSDQ team kind of stays on top of that.
Okay, so I guess I don't really know the process because like we do have a hanging encounters report that I'm sure that Ali Reza's group or DARE pulls out to help us around where the hanging encounters are, and that's one of our data auditing kind of exercises. So we probably, I guess what I'm thinking is we need to go through some of those things and see.
And make sure that it's covered.
Yeah, right.
Yeah, and you're probably talking to the wrong people because this is something that Sally and her teams usually handle. So I'm sorry if we don't have good answers for you right now.
That's okay.
So this is Ali Reza, if I may.
Oh.
Sorry, I just joined from the UC comment.
Perfect.
So I think there are two types of reports that we need to, I guess, to discuss. Number one is the patient level kind of clinical informatics kind of reports that because of the gaps in CW Cerner analytics was trying to help in the past. So now going to CST, I believe that goes to the triage meeting when we identify all these requirements. And thanks, Susan, for, I guess, highlighting those for us because we shouldn't lose track of them. So that's something usually that is, if it is for day-to-day clinical decision making at a patient level, that's something that probably, I guess, CST team will help us with that. And it goes to the triage meeting, and I think Lucy and Peter Bronco will discuss that and figure it out. Other than that, I think there are the aggregate reports retrospectively or require joining with other data sources that usually falls in the analytics side of things.
So it sounds like there's a forum, Ali Reza, where we can bring this up and do that reconciliation or that discussion.
Yeah, and I think in all the conversation we heard that the reporting requirement and analytics requirement from the program needs to be identified. So I don't know where is the formal table to share those requirements, Susan, but I'm happy to work with you to, I guess, list them together based on the limited understanding I have, and then probably if we can identify which table or person we can send it to, that would be wonderful.
So is that what CST on this call, is that sort of what you're recommending? We go through, like operationally, I can go through that with Ali Reza, and then we send that off to, it sounds like, CST Analytics?
CST doesn't have an analytics group. Why don't we take that away and we can talk to Sally, who owns sort of the reporting team, and see what that process should look like. I think it's a little bit bigger than today's session.
Yeah, for sure. I guess just with the we got a little off track with this reporting. You know, it always feeds for me though, like what's in the system to get out of the system. So that's how okay. I appreciate that. Thanks.
I guess just from my perspective as well, like I think we've been asked in multiple design sessions, like, hey, what reports do you guys use? I think the trouble is, I wouldn't have thought about that clinic whatever location thing as a report. So I think that's part of the problem when you ask me, is like, hey, what reports do you want? I think the other piece, just to tie back into Susan, like we don't understand all the reports that operations is using for our clinics. So like, I think kind of like we're having a larger discussion this afternoon about whatever it is, triaging, that's probably its own completely separate discussion that sort of ties into every clinic in the entire hospital. Okay. But moving on to encounters.
Just out of curiosity, when you said that you wouldn't have considered the like daily appointment slate a report, is there a more frequently used term that you would say?
No, you know what? I think that's the problem. It's sort of like when people asked us for our forms, like nobody knew what that meant.
Okay.
So like we just started collecting like every piece of paper we use, and people didn't know what it meant. And so I think that's half of the problem with the design sessions is like, we all use different terminology. And so that's why I was sort of asking in other design sessions, like give me a list of like 10 most common clinical reports, and then I'll understand if I use them or not.
Understand.
I don't think there is a more common terminology. I think we don't know what to call it. A list.
A printout.
Yeah, exactly.
Yeah.
Yeah, sorry. So moving towards encounters. So initially we thought the pulmonary function lab location will be combined as well. But it sounds from CAT, it sounds like the pulmonary function test location will be kept separate anyhow.
Absolutely.
So there's actually no pros of merging location in terms of the encounter. Because if a patient is getting a PFT before or after an asthma or CF follow-up appointment on the same visit, they would still need to have two separate encounters that created to each corresponding location. So the PF appointment will be attached to the pulmonary function lab location, whereas the follow-up appointment will be attached to either asthma or CF. So these actually won't apply anymore. But in terms of cons of merging location, it will be more difficult for encounter selection. So I will just going to show a screenshot. So basically during encounter selection, this is what you will see as part of the encounter history. So once the location for asthma and CF and respirology is combined into one core location, from the facility, you will only see the same location. Unit clinic, you will see the same location. Medical service, you will see the same respirology medical service, and encounter type, you will likely see multiple pre-outpatients. If the patients have a multiple pre-outpatient encounter for asthma or CF or respirology, you won't be able to tell from the encounter selection which one is for which subspecialty. So this is what will be more confusing for the clerk.
And this is really what, in my mind, the key point to make is that if we were to collapse the respiratory clinics, it becomes difficult from an end user perspective to select the correct encounter to either document or enter their orders on, or if you're a provider trying to review what happened at a different clinic, it becomes really difficult from an encounter selection when it's a one-to-one between clinic and service, but there's actually sub-services.
I think this will be, I think it highlights for me that there's a need to have, we need that level of detail at the clinic level.
Mm-hmm.
Yeah, but I guess part of, when I'm pulling open my Cerner right now and looking at sort of how we use this encounter type and locations, the reality is like the vast majority, 99% of patients in respiratory are owned by one service.
Okay.
And so it's sort of like, yes, it's possible somebody in CF clinic could be seen in sort of, I don't know, sleep clinic, but like 99% of those encounters are CF. So I guess the difference would be now, instead of saying all these different things, it'll all just say respiratory.
Correct.
It'll be a different location for PFT lab.
So that's in the considerations document that we'll be talking about at 3 p.m. today. It's if they have the potential to have multiple pre-outpatients to the different sub-services at the same time, that's when you need to consider it. But it sounds like that's not respiratory's problem.
Yeah,
Right.
this is Ali Reza. From the analytics perspective as well, if we need to report on the subpopulation within the referral, if I speak, I guess, CST language group, then we can't really delineate that because the sub-services are not delineated, right?
Mm-hmm. And so it might be contained within the appointment type, but not in the location or the service.
Yeah, and we know that the referral, especially for surgical clinics, the referral to the first consult, surgeon consult, is really important for ministry, and that's the wait one. And we know that we have that requirement from ministry to report that going.
Well, and we're mimicking that same standard in our waitlist management across the medical clinics too. So those are, I guess those are key kind of points in time that we have to be able to pull out.
I think I'm still a bit confused, this conversation versus perhaps sort of the reporting piece. So maybe if I understand, so there needs to be a need to generate a list by, say, like CF, asthma, whatnot, for the wait list, also for the number of patients seen, which I'm hearing can be done in ways other than location. What's this other kind of report that requires sort of various locations?
So if I may share my understanding and correct me, everyone. So in I guess children's ambulatory, we have, I guess, let me share what we call the different part of the journey, and then I share the same understanding that I have from CST side of the world as well. So when a patient is being referred, we call them waiting to be booked in basically in ambulatory. Then when they have a booked appointment, we call them they're waiting to be seen. We consider both as a part of waitlist. Now, from what I learned here is when a patient is referred, then I guess in CST they call referral list versus waiting to be booked. And when they are booked, then you have appointment information, which I imagine is a potential solution to, I guess, providing the sub-service information from that point on. And in CST language, it is called waitlist from that point on. In current setting, we call the whole thing waitlist.
Kat, Ali Reza brings up a really valid point. So let's say we want to split out the wait list. So instead of having a single wait list, we want to create the subspecialty wait lists because we've collapsed the location and we now want to split out the wait lists. Have we ever had discussions on what that data looks like and whether or not Ali Reza then would be able to, like, or is that a front end function more than a back end data thing?
And I'll have to take this away and bring it back, but I'm thinking about hereditary cancer program where we made them 8 wait lists, and I'm pretty sure that helps to give them the information that they need about how much time each patient is spending on which list. So we will take that away and get back to you. And just one other comment, Ali Reza, I think I heard you say that once the appointment is booked, then we have appointment information. But I also want to point out that as soon as the referral is written, we also kind of have appointment information as well, because every referral order, internal referral order, is associated to one appointment type. And so if we have a patient who has a referral to asthma and it's the first referral, it's associated with the asthma new appointment type. And so no matter where that patient is in their journey, we can get the same information just from a different data point. And you're correct, at CST, we don't call it a wait list until they are waiting to be booked. So any time in between referral and the provider triaging, we're not on a wait list yet.
Sorry, waiting to be seen, right?
Yeah, waiting to be seen is nope. So if someone is booked, they're not on a wait list. If you're booked, you're not on a wait list. If you're waiting to get booked, you're on a wait list.
So you're waiting to get booked. So they haven't gone to the scheduling yet, but the pack of referrals that are sitting on probably the request list.
That's not a wait list.
That's not a wait list. Yeah.
That's a request list.
So those are important, whatever we call them, those are important data points for us to be able to pull and report.
Sorry, I'm a bit confused now. So what is the milestones in the journey of patients before they are getting the visit?
So for an internal referral, the first milestone is the referring provider writes a referral order, and they would write referral to asthma. And now you have a patient who is on a request list, and they are waiting for the provider to triage. They're on a request list, they're waiting for triage. And then after the provider triages, they are waiting to be booked. And at this point, the clerk has 2 options. They can either book the patient or they can move them to a wait list. If there's space, and depending on the clinic's operations, they can book them. Even if they're booking them for a year from now, they can still book them. Or they can move them to one of many wait lists. They can move them to the asthma new urgent wait list. They can move them to the asthma new not so urgent wait list, etc.
And can you just continue following that path? So then patient is scheduled and arguably they're still in, like, operations eyes, still on a wait list if they're scheduled like a year from now, right? And so what would that be on a scheduled list, or where would we get that kind of information?
That would be a report. That would be information about what your bookings are. So what types of appointments you have booked and how far out are they?
Okay. And then patient is seen.
Sorry, Susan. What do we call that list in CST?
That's just a report. We don't call it a list.
Yeah,
if they're booked, they're
not a
booked.
function.
Yeah.
So it's scheduled report, or the
We would
report.
have to look into that, but we don't consider your booked patients to be on any kind of list. They're booked.
Right. And then their patient seen, and then what's the flow for, we saw the patient and we know we have to book them again in a month from now. Do they go through that whole list again, or that whole process, or do we go straight into scheduling them?
That depends on your clinic's process. So the provider would write a follow-up order.
Mm-hmm.
They would say a follow-up asthma book in a month. The clerk would receive that request on the request list. And again, the clerk is faced with a choice, either book or move to a wait list.
Right. Okay.
Can I just clarify that though? Because I guess the hole in this system, if we merge, is really from request list to physician triage, because that's sort of when you have these just completely undifferentiated patients.
Yes.
But like from my understanding, like unless you're a clinic that just does not do a good job of triage, usually patients shouldn't be sitting on a request list for a very long period of time. And then technically all the internal sort of follow-up appointments so those still go through a request list, but then I guess like the physician doesn't need to triage that because we've essentially done that already. Like then the clerk just goes right from that request list and pops them on to either booking them or puts them on a wait list.
Correct.
Okay, and then yeah.
And the problems with the consolidation for a triage is something we're going to get to.
Okay.
Yeah.
And then just so I understand, because I will say like 90% of our referrals actually are not going to be internal. They're going to be external through WorkQ Monitor. So I'm guessing that's really exactly the same process, except sort of the separate steps of working through WorkQ Monitor and then doing the triaging from there. But as soon as it jumps off of WorkQ Monitor into the request list, it's like an internal referral or not really?
Similar, yes. And the way we manage that is when the clerk is creating that referral encounter. So they're sitting there, they're going to attach the documents. There's fields in the referral encounter that say date and time request received. So if the fax came in 3 days ago and we're just getting to it now, then in that referral encounter, we put the date and time the fax came in. And then that's captured there. And then you're right, then it flows into the same process where it waits for a provider to triage.
Okay. So thank you for describing the journey. That's very helpful for me to understand it. So quick question. If the patient is external on the referral part of the journey, then we cannot delineate between the sub-services. Is that correct?
Very similar to internal, because they're all going to come into the same kind of request list and land on the same land on the same triage list for the provider. So if we had separate locations, then the clerk would look at the external request, so the fax, and they would look to see what subclinic the provider is requesting, and then they would create a referral encounter for that specific location. So they would create an asthma referral encounter. But if we merge the locations, then the clerk will be creating a respiratory encounter with a respiratory medical service. And so we will get to in a minute the impact of that.
Thank you. So just to confirm, that means that if we need a certain subpopulation to be monitored in terms of their referral wait times and so forth, then we need to have a specific location for them. Otherwise, it's going to be merged with everybody else in that location.
That's correct. You won't get specific information for those external referrals until
the appointment's booked.
The appointment is booked.
Yeah, so retrospectively, you could look at that appointment, but if you need to do it at any point before that, it won't.
But won't we have that information on the wait list?
You can move so yes, you're right. So at the point where the clerk has to decide if they're in a book or wait list, they can move the patient to a wait list that's called asthma. So you can get it from there. But I think what Ali Reza was asking was any time up to that point, so any time after we receive the fax while we're waiting for the provider to triage, we don't have specific information at that time. It's generic for respirology until the clerk is faced with that action. Am I going to wait list or book? And then we get that specific.
The location.
Yeah, if we collapse the locations, then we get that specific information.
And I guess like this is our clinic and maybe other clinics are different, but from a provider/physician workflow, it's fairly unacceptable to not triage your referrals, what would be considered in a timely manner within the week. So like I wouldn't expect that request list should be backing up because we triage daily.
Yeah. And that sort of process, right, versus I think what the system can do. So that's the best practice. I agree, Connie.
Okay.
Yeah.
Are we all on the same page then about sort of all of the lists and pros and cons? I think the next piece is, and you'll probably get to it, is the whole triaging thing. But I think I have a better understanding of that anyway.
I think we just have a couple more smaller items to go through first. So if you want to go ahead.
Yeah. So next one I have is label and face sheet printing. So this one is like a very minor impact, but I still want to bring it up. So basically how we do our distribution for label and face sheet printing to printer is that we have a one-to-one relationship between the core location and to the printer. Primarily, we set up the label and face sheet printing based on core location. If the clinics are planning to use separate printers, then printing can't be set up based on core location anymore because we can't have like one core location to separate printers. It can only be set up by specific PCs. And from our perspective, it is harder for us to maintain printing setup by different PCs because we need to do some build adjustment whenever there's changes in the PC location when you move around the PCs. But this is something that we can accommodate. But if the clinics are planning to use one printer for labels and one printer for face sheet anyhow, then all the printings can be easily set up to one printer if we merge the location. Does that make sense?
Yeah.
Okay. Any questions for this part?
The only addition I would say is that if any of the services within Respirology require different documents to be auto-printed at time of check-in, like the face sheets, armband labels, the number of form labels. If you need, 10 form labels for an asthma patient, but only one for a CF patient, if we were to collapse the location, we'd have to just agree to one setting for how many labels to print across all clinics.
Yeah, exactly. Thank you for bringing it up.
Can you clarify what's a form label?
We preprint the FormFast form labels, so you can stick them on any paper in the chart so that when it goes down to HIM for scanning, it has like the patient address graph information on it.
Okay. Yeah. And I think like still TBD is like which, if any, of our forms will be in FormFast. So I don't know if so that. And then I guess just to clarify for specimens, if we are not sort of going on the nurse collected specimen workflow route, so is that part of that? Like you print up, you have to decide by location, like every clinic we're going to print out X number of specimen labels?
Yeah. And you can go in and ad hoc print a specimen label later. It's just per clinic, you have to decide how many of each you need to print at check-in.
Okay, and that's by location?
It's by location, yes, correct.
Okay.
So if your needs drastically differed, that's just one thing to consider.
Okay.
Yeah, that's everything for label and face sheet printing. Next one is document note types.
Yeah, thanks, Valerie. So under document note types, so if we merge locations, will not be able to filter notes by location, and best way to filter will be by other ways, like if we can mention that in title of notes, or we can filter it by the author name and or the contributor. Otherwise, you will be seeing all notes under like one location.
Okay.
Can I just understand that title of notes then? Is that something that you is a free text field, or is it a standard kind of document? Here's the note for respiratory, here's the note for asthma.
Yeah, we can change the notes title. Yeah, so we can like point out and specify for which clinic it is.
To be standardized.
I don't think it can actually.
Yeah.
So, sorry.
It's just Brenda here, Suk. Susan, for the note types, there's different types. You can, it all depends on sort of what was built, but the actual note type is pretty standard. So you would see, pediatric respirology, clinic note, or say, for example. However, the subject is a free text. So that note type would be used in all the clinics. And then, for example, Connie, if she's working in asthma versus CF, she would then title that differently. So what clinic is that way. Again, that's also user. Some people forget to, and then you might get a lot of free text notes. But generally speaking, once we sort of do a lot of education, it's just the title that will really differentiate.
So I'm hearing that filtering by title could be a bit problematic then, based on that.
Yeah, the reason for that is mostly if people forget to change the title, and if it's a free text template, all we would have is subject free text. The note type would be respirology clinic, or say clinic note. You can look to the author to then get a little bit more, but it really is user dependent if it's a free text note. Generally speaking, though, when we look back, people do get quite used to it, because I think they do save, a few free text notes and then realize, that it's harder to find. So I think the end users definitely do get used to actually changing and making that subject line a little bit more specific.
I know that at one point Connie had asked, how would I see all of the asthma clinic documents in the documentation tab? And if it is built as its own location, you can pull out those specific asthma clinic documents, but then we do lose that granularity if we build it as one location.
Yeah, I guess with this slide, I'm kind of leaning towards it's we don't want to be merging based on this conversation.
I think Susan, this goes back to the same issue that Connie mentioned earlier about the encounters, which is that the majority of the patients are under one subclinic. So I think this would be the same level of issue as having a single encounter under respirology. If a patient 99% of the time is going to asthma, then this wouldn't be a problem.
Mm-hmm. But I think the other piece is like, who is this sort of document note typed for? And I guess for us on the user end, none of this really makes much of a difference, because when I look at my documentation tab, and this is why I was so obsessed about the event set hierarchy, the new event set hierarchy, regardless of whether we have 10 locations or one, everything says respiratory. Is that correct? Like if I decide I want 10 locations, am I going to get 10 different clinics on an event set hierarchy?
Yes.
Okay, so that is different then. And that is not the event set hierarchy that I got though. Is that because this is still being decided, or?
So just to clarify, you're going to have the, if we're talking about the note types, those standard set of respirology note types would remain regardless of merging the locations.
Right. So like maybe I'm not understanding this correctly, but when I look onto the system now, the sort of two main headings for which I search things in the list, and I know there are fancier ways to filter and blah, 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 but the way I actually look at it and the way most people face up look at it, right now, it sort of has each individual clinic. But my understanding is that in the new event set hierarchy, everything says respirology. Is that correct under note type? Whether it's for CF clinic or asthma or any other thing, or do I not understand that right?
No, that's correct. It'll be one note type that's a respirology pediatric clinic.
Exactly. And so even if I decide to have 10 locations, that's not going to suddenly in the event set hierarchy give me 10 different note types?
Correct.
Correct.
Okay. So Susan, maybe I can understand from an operations perspective, how do you guys use this note types?
Oh, well, we don't. I'd have to go back and see how how it kind of affects nursing. I'm sort of thinking, I'm just trying to understand the con of this, like how it's laid out. And, when I think of a provider going in and wanting to make sure, like seeing a patient who goes across ENT, respiratory, different areas, we'll want to make sure that it's organized in a way that they can see all those different areas. That's where my thinking is at, Connie.
Yeah, totally. And I think like that was also my sort of feeling as well. But my thinking is that is really then the event set hierarchy, because the main way that notes are sort of separated out is by that event set hierarchy, not by locations. And so like I think that's why, I don't know, I suspect that event set hierarchy is like carved in stone, but like, because I totally agree, like relying on people to type the right thing into a free text box is a terrible way to sort things. We've learned that the hard way.
Yeah.
And is it even possible to sort by title? Like the free text title, is it just alphabetical or something? Or how does that even work?
Yeah, so you can sort by title, but you can filter by your note type. So we have predefined filters in the documents component where you can, choose you only want to see nursing, you only want to see surgical or whatnot. But if you want to sort, you would click the title and then that sorts alphabetically. But what you would be losing if you merge location, it would be the filtering by encounter. So that there's one button that allows you to filter the documentation by encounter, and then in doing so, it really nicely highlights where that document was associated to. So if you merge your encounter or if you merge your locations, it's all going to be under that, like a REST note, a CF. Yeah, it would all be under one.
Yeah, and I guess from our perspective, and it goes back to this encounter business, is like it's actually rare within the division that it's that necessary to sort of separate out those locations. I think the main thing that I was sort of hoping for, but I understand this is not possible, is that in the actual event set hierarchy, our respiratory nurses could actually have a note type that says nursing note respiratory. So instead of sub-filtering by location, which they can do, it would actually be in the event set hierarchy, but I know that's just not possible. So I think I understand the sort of implications of this, which are not huge from our clinics, but
I do wonder, Connie, like I'm stepping back a little bit and I hear what you're saying for your division. I wonder, like, when the doc in ENT is trying to see if there was a sleep lab test done or not, we want to make sure that that's kind of filterable in an efficient, quick way for them. What I mean, right?
Yeah, and I think like from my understanding, probably the question is like our diagnostic tests, which I think I do agree, this idea that the diagnostic tests all need to have their own location. So I think the sleep lab and the PFT lab have to be separate locations for that reason.
I agree.
And then whether all the clinics, like whether an ENT doc cares whether somebody's seen in sleep clinic, RESP clinic, or CF clinic is probably the question of locations. Correct?
I agree. Yeah. I guess I do feel like, so some of the questions we get is when we're trying to pull out, how many like asthma specific kind of questions from ED or Gen Peds or those kinds of things. So that's sort of where I'm thinking, but yeah, this is all good conversation because this is what we have to delineate if those need to be separate, which I feel like I'm leaning towards as we walk through this, the pros and cons. There seem to be more pros of keeping them separate.
Yeah, sorry, it's Brenda here. I'm just trying to get to try to find a patient in our system so we can show you, maybe Susan, so maybe you can get a better understanding. Unfortunately, I can't find one that has a lot of ambulatory visits, but I can sort of share my screen if you want to see sort of what the difference would be. Like when we talk about, when Mila talked about grouping by encounter, it just gives you like a little header, right? And so, for example, unfortunately, this patient mostly has inpatient and has their visits, but there's been some that will have like a a header that says, say pulmonary function lab, and then whatever documentation's done under that encounter lives there. And then the next header would be, say EEG lab, and then whatever documentation's done under there. So if we build the respirology clinic separate, that's sort of the way it would appear. So it is a little bit easier to find documentation, but then again, it is up to you. I just wish I had a patient that actually had more ambulatory visits so you could see what that would look like if you guys are more visual.
Like, I think I get a sense of it because I think this is actually how our system currently works, except actually you guys are completely collapsing down our event set hierarchy. So in fact, the new event set hierarchy has far less granularity than our current system does. But I don't think that's a conversation, that's a location question.
Correct.
But you can sort of filter by location. I do get that point.
And we, even with our event set hierarchy maybe not being as granular, there's still hundreds and hundreds and hundreds of document types, but we're also, interfacing to a bunch of systems that can't necessarily handle a lot more granularity than that.
Yeah, I kind of figured. Yeah, so I think that's fair enough.
I have a question as well. I think in the last week I heard that the order set will be kind of finalized in May, and there's not going to be any addition to that. Does that have any correlation with the list of locations or appointment types or stuff like that?
No.
Okay.
Yeah, I think those are sort of independent of all locations, like our pre-printed orders and stuff. You can kind of use those in any location. They're, I don't think, tied to a location or appointment type or anything like that.
On occasion, you can, if there was a specific order set that you don't want available at all locations, you can restrict it by location, but I don't think for the most part they don't do that.
We try not to do that.
That many.
So there is no need for, I guess, using any orders when we are putting a referral or something across that journey, like through that journey that we went through.
Say that question again.
So I'm wondering, I'm just trying to learn what is the impact of, I guess, that decision in terms of locations or in terms of the workflow of from referral to actually patient is being visited or has their visit with the provider. Is there any point that this may pose any, I guess, limitations as we design the system in maybe 2 months from now?
From an orders perspective specifically?
Yeah.
Nothing that I can think of. Really, I mean, from one of the things that I have on my list is like that order and requisition routing is based on clinic location. So if you had vastly different requirements, you probably wouldn't want to collapse them, but I can't see that being the case within respirology. And usually the lab collection default is based on location as well, but I'm assuming
it would be
not a lot of,
Okay, thank you. And just seeing in terms of the, I guess, cons of merging location, it says that orders cannot be differentiated.
Reza, I'm coming to that.
Hey, this is April. Hey, I'm from the ambulatory team. So with the referral and follow-up orders, really in this situation, we can go either way, just to put it out there. But yeah, con of merging the locations, you would have like one generic order, like referral to respirology. That's just one generic order that encompasses asthma, sleep, general rest, and whatever else. I mean, okay, so your options are we can either have one order that encompasses all of those, or if you differentiate the orders out, you have referral to asthma, referral to sleep, referral to CF, referral to HTV. Either way, these can be done.
Can I just clarify, April? Because I think what I'm hearing is actually we can do either. So either we build out separate orders, which is independent of location. Is that correct?
So we can do either. There would just be some work on the back end for us to make sure that this happens for you. So for example, with the referral to order, like referral to respirology, there's going to be a field in there for locations. And it's not tied to the core locations that we have built in that tool. This is a separate build, and we can name it whatever we want in that field. And we will just have the mapping for scheduling, whichever one you choose. The mapping to go to scheduling would have to be, figured out for that to happen. And
but
then,
if they built out separate core locations, would they then have a referral to asthma order, referral to CF, or would it still be referral to respirology and then they select within that order?
if they had, okay, so here's the thing. If they had different orders, so like all the different locations, referral to asthma, sleep, risk, if we had it broken out by location, then you would have an order for each one. So referral to asthma, referral to HTV, referral to sleep, referral to CF, that type of deal. So
But
it just,
sorry, but I'm understanding that actually you can build out those orders even if we don't have separate locations. It just requires different back-end work to map it to the right place.
yes.
Dr. Yang, it's Kat. I wanted to jump in to clarify, please.
Yeah.
If you keep separate locations, you only have one choice.
Yeah.
You have to have separate orders.
Yeah.
If you merge locations, you have two choices. You could keep separate orders, and I'm thinking about myself as the referring provider trying to find the referral for asthma. If you keep separate orders, then when I type the word asthma in, I'm going to find the referral to asthma order. If you combine into one order, referral to respirology, and then within that order, a provider chooses asthma or CF or whatever, it means that when I am sitting there typing the word asthma into my search bar, it's not going to come up. Only if I'm looking for respirology would it come up.
Okay, so the sort of highest level order, sort of referral to respirology, CF, whatnot, that actually is determined by location. But whether we build out within that order as a separate thing is not determined by location.
That's right. And the options in the list. So if we build a referral to respirology order, and then there's a list in there, asthma, CF, whatever, the things that are in that list have nothing to do with your actual core locations. Sometimes it's a completely different part of the system. Yeah. So we can make that say whatever we want. So from my perspective as a referring provider, I think in one of the demos we showed you a referral to St. Paul's Elder Care. And when we built that order, we did build a referral to elder care, and then inside the provider is forced to choose whether they want Jerry Psych or just Jerry New or psychologist or whatever. And we did that because we want the provider to be forced to look at all of their options, because the patients can see one or many clinicians in that clinic. I don't think your clinic's the same way. I don't think you want to use the order to force the providers to understand all of your subclinics. I think they probably know. Have I got that right?
Yeah. But okay. Can I just clarify though? So is it impossible to actually build out two, like you can't actually build out a referral to asthma, referral to cystic fibrosis if it's one location? That's impossible?
Right.
Okay. And
wait, so no, if it's April, if it's one location, you absolutely can't have multiple referral orders for one location.
Is that our enterprise though, or goes against enterprise?
I don't think that goes against enterprise, but maybe April's getting.
So if it's one location, then I would feel that we would need to have that one field with the options of the different locations. So if you did one location, referral to respirology, we would still need to be able to communicate to scheduling where exactly is that patient going to be going.
Right, April. But if we have one location, we can have referral to asthma as a separate order and referral to CF as a separate order, and they all funnel to the same location. That's completely acceptable.
Okay.
So sorry, if I ask too many questions. Just to confirm, so if we have a deadline for the order sets to be finalized, that means that we need to make a decision about locations before that, because if we want to separate a certain location to multiple locations, that means you need to have new orders, correct?
We would need to make a decision about your locations a month ago, because all of your build is dependent on your locations, not just the order sets.
Correct.
But like, can I just clarify though, like, is this most important for the ambulatory locations going live? Because like,
Yeah.
from what I understand on the
Yeah.
inpatient side, there's not that much issue about locations. They are where they are. And 99% of our order sets are attached to inpatients. Is that sort of, or no, is it sort of more complicated than that?
I think that your statement about the inpatient locations is true. If we don't have a lot of work to do there, they're not usually a question, but because the way that we build clinics in CST Cerner is different than the way that you build them in CW Cerner, we do have analysis and decision making to do.
Yeah, and I think, like, to be honest, like, that's why it's good to have these like bigger discussions now, because I think the way we think about it in the system, it's not just going to, we need to think about it for rest, but like, for example, am I going to refer to GI and then as a sub drop down, I can refer to hepatology clinic or general GI clinic, or are they just accepting everything under general GI? And then it's up to their providers to decide what clinic they go to.
It's completely up to the clinic's operational workflow. If they don't trust you as a referring provider to decide what clinic, then they're going to force you to enter a generic order, and they're going to look at your referral first and then decide where the patient's going to go.
Right. Okay. So I guess what I'm sort of hearing, though, is either way, collapsing locations, not collapsing locations, we could have separate orders built out for different clinics if we're okay with the referring provider deciding what clinics people go to, which I would say 90% of the time it's right, and 10% of the time we have to move them to a different clinic.
Yep, and we're aware of that, and I think it's the same for respirology at St. Paul's, so we've already kind of looked at that workflow.
Okay, so then in that sense, does this collapsing locations, not collapsing locations, make any difference on that sort of like refer to X clinic decision, or those are, now we're done with that?
It only makes an impact if you want one order. If you want one order that has a list of your clinics inside of it, you can only have that if you have one location.
Okay, yeah, I think like, yeah, just to be clear, I don't think we necessarily want that. Functionality isn't sort of like that. I think what we would ideally have is like refer to the various clinics as separate orders, so that when the ER doc looks to make a referral to asthma clinic, they can actually just search refer to BCCH asthma and find the right thing. But from my understanding, that isn't reliant on location.
No.
Okay, awesome. Okay, sounds good.
Okay, referral and triage. So I was gonna demo to you all. Let's see. What's next, Suk? Oh yeah.
Yeah.
So Dr. Yang, so remember I sent you an email regarding the reference text for the internal referral order. So I wanted to look at that, the example that I had. And that was referral to PHC, elder care. And the purpose of this reference text is to assist the provider in appropriately getting the patient scheduled.
April, are you showing us your screen?
Oh, I'm sorry. Excuse me, sorry.
Thanks.
Thought I was sharing.
And I don't know if we need to go over this right now, April, because it's not really about the location.
Okay, so don't worry about it.
I don't think so. This is the way that we can help support your referring providers to find out more information about your clinic. And so if you have separate referral orders, sometimes we can be more specific. And if you have one order, like the elder care is a great example where they have listed all of their subclinics there to help the provider choose the right one. So if you wanted one order, that's what we would be taking you through, but it sounds like that's not what you want.
Yeah, I think that's fair, actually. I think it's a whole other discussion about how we get the sort of right information, but so we might use this anyway, but perhaps not in this way.
Yeah.
Okay, so that's all we had for our co-location discussion, and I think we are more clear on like how it's
We
going
need
to
to talk about
impact. Yeah.
triage.
Yeah, so we'll be covering triaging piece in our referral triage discussion. And so for that, first was to discuss internal referral order, and then we can talk about referral and page.
Can I just make one additional comment about
Yeah, sure.
something to consider about the collapsing or not collapsing is that automated appointment reminders, I don't know if you're currently using automated appointment reminders, but the ability to turn that on or off is at the location level. The number of days in advance that you choose to send the reminders is based on the location. So if you needed to differentiate for CF versus asthma, that's a consideration about your appointment reminders. And the appointment reminder references the clinic location name in the reminder. So I don't know if Respirology is sufficient and that's what patients know the clinic as, or if they know it more as the asthma clinic. So that's another consideration just to throw out there.
And can I ask, and it's sort of related but not, like, so the issue we have right now is like a patient right now gets 2 reminders for a pulmonary function test and say a respiratory clinic visit, which is causing all sorts of problems. But does this system, there's no way to fix that in the new system, is there?
I don't think so. You know, we basically took the design, the automated appointment reminder design from Children's and Women's because we were to build like for like, but we did make some enhancements, but I don't think that is one of them.
Because I think it may go back to Nico's question about this sort of protocolized appointment types, because for some, sorry, go ahead.
I'm not 100% sure how protocol appointments and automated appointment reminders work, to be honest.
I think we need to look to cardiology, so we'll take this away and get back to you, Colette. I think they might be booking the protocolized ECGs under the cardiology location.
Okay.
But we'll follow up on that and get back to you.
Okay, because
I didn't realize that the appointment reminders were going to be part of this, so that's great. However, if there's also opportunity to make some fixes in that, because like Connie's saying, we have a fair number of challenges with having multiple going out to families, especially when they're going across clinics. So anyway, if there's that opportunity, that would be great.
And I think, sorry, go ahead.
I just want to rain on the parade a little bit, because at the stage of design we're at right now, we don't really have any more runway for completely reopening this type of design. I think that what we're working with is, as Colette says, we built a like for like and we did some optimization, and so now when we look at a clinic like this, we can look to see what the impact is. But Susan, I just want to caution, like, we just don't have the time or the bandwidth for redoing that work.
Okay.
I'm just sort of wondering though, even within, I kind of get that maybe it's out of scope to fix this across the system, but even internally, like within our division, probably it's something similar to whatever cardiology is doing, because they must have the same issue. But it does go into a bit of what Nico was saying about how appointments are booked, and our sort of current workflow in respiratory clinic works well because it pulls up both of them, and then when the clerk is booking, they can just uncheck the reminder for pulmonary function test. Whereas for some reason in asthma and other clinics, it's like they have 2 separate things to uncheck or check, and so that workflow has just not worked. But I don't understand on the back end how those were created to create those different options for the clerks, but I'm guessing some other team at CST knows.
Yep, and we can work with Nico on the specific design of AAR for your clinic to see if there's any tweaks we can make there.
Okay, sounds good.
We did meet quite a bit with CNW to understand where their struggles were to try to optimize those, but I just, we can take away the whole multiple reminders question, but that might be something we have to live with for a little bit.
Okay, sounds good.
Okay, so I guess is anyone having any questions we can answer, because we are going short of time and already spend like we just have half an hour to cover the referral triage, and we'll be going over FRM page under this discussion. So April, you can go ahead. I think Dr. Yang is aware of this, and we are following up with her on email. And Dr. Yang, if you can reply back, because to build this we need some information. So April, you can go ahead.
Okay.
Thank you.
Okay, so I'm in PowerChart, and I'm in the toolbar, and I'm going to go to the referral management end page. Okay, so this is what it looks like your first time accessing it. And this is really just a more pretty version of the patient list, in my opinion. All right, and so in this referral management end page, we have some required fields, which is location and referral status. Medical service and tumor group aren't required. Tumor group is for BC cancer, so no need to worry about that. So what you do, you just set up your list just like you would in patient list. So here in my example, I'm just going to choose a location. Let's see.
Can I just ask while you're doing this, because this ties into this question about merging locations versus not. So if we merged our locations, but we want separate wait lists, what does that look like on this referral management end page?
Dr. Yang, this is, and I know this is a problem with our cross terms, but this isn't a wait list. This is your triage list. And so this is one of the main drawbacks to merging your location. So what April's showing you now is the list of core locations, and there's nothing we can do to get around that here. So if you do merge, you would be selecting BC Children's Respirology here.
Okay, and so that means, and maybe to use your terminology, so that request list of random information coming through the pipeline, all the different referrals, that is sort of hard-coded by location then. Like, so the clerk can't sort of manually put things into different buckets. It can only come through a location?
Well, they can, and so what we'll get to, so let's imagine that you've just picked BC Children's Respirology, and then April will keep going through the demo, and then I'll show you the one, I think there's one place we could put them in buckets for you.
Gotcha.
Okay, and then we're going to choose our referral status, which is ready for triage. And then, Kat, are you referring to the medical service to kind of drill down?
No.
Okay. All right, and so from here, we're going to hit run to run our report.
So your medical service would be respirology as well. Like you won't have a choice.
Yep.
April, what about the triage priority? Can we filter by that?
So
only sort.
We can sort.
But it's not one of the.
Excuse me. Yeah, there's not one there. Here, I have a better example. I kind of want you all to see what it looked like prior to having it set up. Let's see. Yeah. Let's see if this one has it. I'm in as the oncologist here.
It's not set up. Okay, so, and sorry, Dr. Yang, this is a brand new function, and so we're not all like super experts at it yet. There is a column there called triaging priority. It is just to the right of the triaging provider. And that column, the value that can be entered there is entered by the clerk when they're doing the first pass at the incoming referral. And the values that can be entered there is very simple. It's numbers 1 through 5. And so what you can do as a business rule is assign CF as clinic number 1 and asthma as clinic number 2, and I don't know if you have general resp as 3, etc. So that will allow you to sort the referrals by kind of triaging bucket or triage priority. I think I'm going to ask to have that also be one of the filters up top. Like I might ask them to change the page. I'm not sure if they can, because this is a functionality that we're going to have to leverage for various clinics that only have one location, but would like one more layer of granularity on the triaging. That's literally the only thing we can do, though.
Can I ask, because I presume, but it's probably a bigger build, like the fact that there's a tumor group, obviously specific for BC cancer, like, is it just way too late to say, like, we need a list of like all the various subclinics at Children's?
Yeah, we can't do that because that would be very hard to maintain, and we'd have to make all subclinics for the whole enterprise, not just for Children's. And that, yeah, so what we would like is to use some other value that's generic. Right now we have triaging priority. And so it's possible for us to change the values that are there. If you have more than 5 subclinics, I can look at adding, getting more added. That would take a long time, but I can look at that.
Can I ask why the med service couldn't be used for the subclinics?
It's always respirology.
Okay.
Kat, hey, it's Mila here. I can help take that request back to add triaging provider. We do have a ticket out to, roll this page out to all the positions. The other item I just wanted to highlight, I know triaging provider, like column is, kind of, you have to scroll to see it. You can customize this view, so you can modify your columns, take things out that aren't applicable, like tumor group, obviously, and then you can move your triaging provider, like maybe to the first or second column, and then really sort from there.
That's a great point, Mila. The other thing the clerk can do is assign the triaging. Can they assign that at in the referral management conversation? That was my question. I wasn't sure about. Because the triaging provider is a relationship, right, Mila?
That's correct. That's correct, Kat. Sorry.
So can the clerk do that or not?
No, the doctor would have to establish a relationship.
Okay, so the only thing the clerk can do is the triage priority.
Okay, so maybe if I just make sure I completely understand this. So we have bunches of referrals sort of coming in, either internal or external. If we collapse all of these locations, essentially the clerk sees one massive list, which is kind of what we had planned regardless. And then their sort of job would be to like sift through them and see which ones are asthma, whatever. They would actually, through some codified system, put that under triaging priority. So that if I wanted a separate asthma triage list, I come into this page, there may or may not be a triaging provider or priority drop down. I select the right codified number, and that's how we actually have separate triage lists for each clinic.
That's the best I can do, yes.
Okay. Out of curiosity, I'm guessing that most other clinics in this hospital have separate triage lists for subclinics, but in your experience, is that not the case?
It's mixed.
Okay.
Sometimes the providers take turns triaging, and if they want someone else to look at it, they'll send it to them. Then other times it's a specific provider triaging for a specific clinic, and we're dealing with the same thing with cardiology, honestly, and the only solution I have is that triaging provider column. So Mila, that's the one that I want added to the filter.
Sorry, triaging priority.
Yeah.
Priority, yeah. Okay.
Yeah. Not just so that you have more power than just sorting. You would be able to actually only look at triage priority 1, which would correspond in your clinic to, let's say, asthma. Like that's the kind of thing you just make a cheat sheet and post it by the clerk's terminal and follow your business rule.
Okay, and then, so for example, I guess the bonus of having one location versus 10 is that if I've now decided that this is not a respiratory referral, it's a whatever referral, I can just throw it into that bucket relatively easy because it's on one list. If we go with the move of having 10 different locations for all of our subspecialty clinics, in order to get them out of this list and onto another list, what needs to happen?
So just to clarify, you can have multiple. So if you did separate the locations, you can choose multiple locations to pull into one list. So you still have that availability in this page.
Mm-hmm. Right.
But if it's the wrong clinic,
yeah,
then if it's all one location, you're right, it's pretty simple to send it to another clinic. We can work with you to figure out the best way for you to do it based on your operation. It can be informal communication to the clerk. You can write a new referral order for the other clinic. The difficulty is actually just for the clerk, because if you have separate locations, the clerk has to do something called a facility transfer to move that referral to the correct clinic. And that's clerical work. It's not the end of the world, but it's possible. And if you have one location, there's no such requirement. The clerk just books the appropriate appointment or sends it to a different list or whatever needs to happen.
Sorry, just to understand that better, that means that we are creating each ambulatory at a facility layer.
Yes.
Yes, correct.
Sorry, we should have prefaced with that knowing you were here, Ali Reza. Yes, all clinics, almost all clinics are at the facility level as a standalone. So far, the exceptions would be T8 will be under the main facility and medical daycare.
That is Cerner's recommendation and basically how they're delivering all future clinic functionality based on the assumption that every clinic is built as its own facility. That's where we get all of the flexibility and functionality.
Thank you, that's helpful.
And so does this change based on like the fact that we actually, most of the MIS sort of referrals are actually external. So on the, if a referral comes in through Work Queue Monitor, can you just run me through, does that make any difference? Or does it all still show up on this list and then keep going?
It's still going to show up on this list because the clerk will have had to make a referral encounter in order to drop the patient on this list. What you're looking at here is a list of encounters that have a status of ready for triage for respirology. Yeah.
So from the clerical, oh, sorry, go ahead.
So from the clerical side, whether it's internal or external, if it's from the wrong clinic, the clerk has to do work to move it to the right clinic. They have to do a lot more work if it's separate locations. If it's one location, it's a lot less work.
Gotcha. Okay. And then if it's coming from Work Queue Monitor, the first step, I guess, is that the clerk needs to figure out, let's just say we have one location. They still need to sort of figure out which of the clinics to assign this triaging priority, and then it sort of comes into this list for us. Is that kind of how that works?
Yep.
Okay, and so technically the other way is if we have 10 different locations, then right at that first, the thing comes in through Work Queue Monitor, they're assigning like a location.
Yep.
Okay, gotcha.
And if they pick wrong or the referring provider got it wrong, then that referral encounter that was created for asthma needs to be changed to CF. Yeah.
Okay. Gotcha.
Yeah. So, Dr. Yang, so we kind of already went through some of this, but you have the ability to save your different lists, modify the columns, move them around. You can remove lists, and then you can clear the preferences altogether.
And out of curiosity, like I'm totally fine to keep sort of chatting about the functionality. Is there sort of further things that we need to consider in terms of this location piece within this referral triage, or that was the main piece?
I don't think so. From mine and Colette's perspective, from my perspective, this is the main consideration here, what you're looking at. And from Colette's perspective, it's that single encounter that's you can't differentiate between any of your clinics. And by single encounter, I mean visually they're identical. It's respirology location, respirology medical service.
Mm-hmm. Gotcha.
And as you described, Dr. Yang, I don't think that single encounter is the biggest deal for you all because your patients are a little tidier than some other locations, I think. But for what we're looking at here, this is my main concern. Because we don't yet have the build to make this work for you. We'll have to do builds, and right now you're limited to 5 buckets, and I think you have more than 5 clinics.
Can I mention one more thing that just to consider from a location perspective is that our document headers, if it's like a respirology note type, which is like somewhat generic, the document headers list the facility or the clinic name. That's kind of hard coded into the report headers. So I know that our feedback from other clinics is that they preferred it to be sort of more specific than just respirology clinic, respirology note. It could actually say asthma clinic, respirology note, or whatnot.
Right. To be fair, I think it's not a workaround, but I think because we're doing all these templated notes, we actually have a full clinic header with all the contact information. So for us, that's not such a big deal.
Okay.
I'm just wondering, I know we don't have a lot of time, and I'm happy to sort of go through the slides if it's more just sort of like FYI about this is sort of the functionality. But while I've got sort of operations and everybody else on the line, do we have more questions, or would you like to discuss sort of this locations piece? Because I think this is the next big thing we need to decide before we can get on with the rest of the build.
Yeah, I agree.
And I guess part of what I'm sort of hearing is like, I suspect like from a data perspective, it is much cleaner to have every subclinic be its own location. Like if I could just summarize the vast majority of probably what I've heard. But to me, it's not just to like keep current locations versus collapse them. It's keep them, collapse them, or actually expand them. Because if I'm following that logic of we want this kind of granularity of data, we actually have way more clinics than what you guys have listed for us. So
yeah, we're aware of that.
Yeah, so I think like if that's the rationale, then we need to expand our clinics and understand what the implications of that are. And yeah, so is there stuff I'm missing here, or is that kind of what you guys think as well?
That's what I think, but interested to hear from Susan and Nico.
Yeah, that's what I think too, is that the granularity means that we would expand what our current is. But I mean, I'd want to go through that list with you, Connie, to make sure we're on the same page. I don't think it's unreasonable, but I think that we need a bit more granularity.
Hello? And I guess, sorry, go ahead, whoever was just speaking.
I think they're just answering a call. Go ahead.
Oh, okay. I was going to say, because I know this is just sort of our clinic, whatnot, but I think part of what our issue is like, it's a bit comparing like for like. So I guess we'd ideally like, you know, all of the clinics to sort of, when a report pops out, it sort of gives us the same information for all the clinics. And I guess, like, if I'm sort of hearing this correctly, I suspect many clinics have the same needs as us and actually a very similar kind of workflow, but they're going to utilize other sort of workarounds to sort of give them that granularity. And I guess what I'm asking CST is, are you guys confident in the robustness of those workarounds?
You're actually in the same boat as cardiology as a minimum, and I'm going to do more investigation about GI. And make sure that we're applying the same solutions, because they do definitely also have subclinics. So you're not alone there.
Yeah, and to be honest, like if I think of the 90 clinics that you guys are about to unroll over the next year and a half, this is like the tip of the iceberg.
Oh yeah.
So like I think that's why I would like to have this discussion now, and like it's easy enough for me to decide like, hey, yeah, I want 10 different locations, but that has some other implications. So I think like, what does everybody on this call feel we need to do, I guess, at a bigger level to make some decisions? And maybe that's a this afternoon discussion. And then we apply that across the board, starting with our clinics. Is it sort of we just need to have a bigger discussion, Susan and Ali Reza, this afternoon?
If I may share my lens from analytics in regard to this, I agree with everything you mentioned, Connie, and I really appreciate all the information that I have learned and you've shared with us in this session. I think from analytics perspective, we follow whatever design that you will require from the operational and clinical lens, because we are here to support you. That said, in the past, because of some, I guess, gaps in the CW Cerner, we had to create our own mappings in the downstream, which caused a lot of, I guess, issues in the reporting and disagreement and discrepancies between the volumes seen on Cerner versus the volumes reported to ministry from there. So I guess what I'm hoping to achieve is whatever design that supports your clinical and operational work, hopefully that is going to be implemented in CSD. And then in analytics, we just mirror that. And we can't create another mapping in the downstream based on location and appointment type and provider list, because our experience is really bad in that terms. We historically couldn't maintain that, and I think that caused a lot of issues. So that is my request.
Yeah, I'll just build on that quickly, Alireza, because I think at Sarah and Jana level, they know of all those workarounds and the acrobats that have to occur. And as an organization, they're looking for that information that we're talking about, the data, right? And so sort of to your point, Connie, I think that if the executive, which I feel they are requiring this information, and Sarah's sort of aware of this, they will need to help support what the work is to roll that out across the clinics. And I know that Sarah's kind of apprised of this. So, time is always of the essence with these CST decisions. I do think that if we were to make our best practice kind of decision, it would mean for respiratory more locations to help support that operational work. And then we would have to keep sort of addressing it clinic by clinic. And if that isn't going to work for whatever reason, we would bring those sort of changes up to the executive level.
Can I just add, maybe this is not the right people on the call, but let's just sort of take a gander and say, is it just kind of impossible to have 200 locations within children's? Because I think that's, if I'm thinking of my own clinics and what that mirrors to in other clinics, that's probably kind of what we're looking at versus whatever it is, 95.
Yeah, that's really the fine balance. I think that's the hardest part probably, is determining or going a little bit granular without going over the top granular.
Yeah, and I think you guys have sort of laid out, at least from the clinician perspective, I think I have a fairly good understanding of the pros and the cons.
Mm-hmm.
And I guess maybe this comes down to the reports and all of that kind of stuff for operations to understand how granular we need to be. Because to be honest, from my perspective, I suspect these workarounds would actually work for us. But I suspect from a reporting perspective, that's not going to work so well. But I think, for example, if the conversation with cardiology is, hey, it sort of just seems a bit odd that one clinic kind of uses this workaround, but it's not going to actually be very robust. It's either we think the workarounds are robust and give us good data, or they're not. And so, I get that there's sort of a fine line, but probably respirology having 10 clinics and cardiology having 2 probably is a bit weird. If I just sort of think of this internal, this whole logic pathway that you guys have walked me through,
mm-hmm.
I'm just sort of thinking that probably doesn't make a lot of sense.
Well, I think it is this balance between standardization and having enough customization for the data. I will say, Alireza and I have been looking at data in the clinics for the last however many years, and there are areas let's take dermatology, for instance. They actually don't require all that granularity, even though there's a lot of different, they would say sort of sub-clinics, but we don't need that because we can pull the data out in different ways. For example, they have a rheum and derm kind of joint clinic. We don't actually need a clinic named like that because we can pull the data out in a different way. And so I think how I'm looking at it, Connie, is almost like population groupings is what we're lacking in the existing Cerner, and that's what we're trying to capture here. And that's how people often talk about their clinics, but we don't want to go all the way, it's a bit of a balance between how much granularity we need. So for me, I find it a little bit challenging to do comparators across the divisions because they are different in a lot of ways.
In which case, maybe this is not really for the CST people to sort of be in a meeting on. Maybe I sort of, or Sharon and I and you need to have a conversation about what is it that operations sort of needs from our division. Because I think we're just in a very odd position that you guys are used to looking at the data broken down by location, just historically for us, and you're not necessarily used to looking at that for other divisions. But for example, if you can pull room dermatology clinics in some way. Maybe there's some other more creative way of sort of doing this, but maybe that's not a CST discussion. I think I'm understanding from CST what they can build and what the potential workarounds are. Do you guys sort of feel like you've got enough information from CST and now it's just an operations to our division kind of discussion?
I think one comment I have, if I may, is that I think that finding that sweet spot of the balance is really important. And I think maybe another option that we can, I guess, look at, and I would like to learn more about that, is the medical service. I remember in St. Paul's, when we went live, we had the option of adding more granularity into the medical service to identify certain population. Is that an option as well?
The medical service is enterprise. It was really decided with clinical informatics and the provider working group what level it would be broken down to. There was a ton of work into it. It was one of the hardest decisions to get agreement to. Where we know we need an additional medical service or two to support some sort of workflow, we can, but we have no appetite for going down to the level of granularity that some of the sites previously were at. Some sites had 50 medical services previously, and like St. Paul's had 1,500 medical services previously.
Right, and I do realize that this is gonna probably be a kind of longer process for that. I'm just suggesting that this may be another option in addition to the, I guess, the balancing that we can do to the location. I'm aware that in women's hospital we want to create, for example, a certain population for fair unit, which is like for the substance use population in the maternity area. So I'm just suggesting that we should be, I guess, open to different options and be creative and work together on that.
And I'm guessing is some of the challenges here essentially like whatever is sort of decided like a way to capture granularity. It's not just our site. Like if we decide we need kind of like tumor board, we have like 50 of these things. It's got to be 50 that everybody across all of the CST sites agrees on.
For things like medical service, it's absolutely enterprise. We need agreement from everyone. So we have a little bit more flexibility on the location side.
Yeah.
That's more site specific.
Yeah, I'm just sort of thinking like, for example, like clearly there was some decision made for BC Cancer to have tumor type there, which is irrelevant for many CST sites. But for example, like having a thing that just says pediatrics, and then we decide on sort of what that is for our hospital. Is that sort of like as a way to capture granularity so we're not building out a bazillion locations which has so many different downstream issues? Like, is that an option or not really?
I want to echo the same comment because I guess the same way that cancer was able to create, I guess, the tumor group for their specialized care that they're offering, I think we can consider children's and women's as a specialized care delivery areas as well. So maybe that's something that we can consider. And when we talk about enterprise, my experience with enterprise is that for the site that kind of started earlier, the requirements of enterprise was more kind of geared towards their needs. And as we go through the different sites, we need to add to that enterprise understanding, right?
Yeah, to a certain extent. There's some teams that with more foundational build where enterprise involved everyone, and it wasn't designed with coastal specifically in mind. So yes, but absolutely. Every time we come to a site, we look at that enterprise to see if we need to make modifications. We just can't like completely site localize anything. That's very foundational. I'll have to let Kat speak to the tumor group, and that tumor group specification for BC Cancer was a last minute design.
Yeah, we had to do that because of two main reasons. Number one is their analytics, because their patients can visit any number of their internal clinics, but they need to be able to report based on tumor group, essentially. So the patient population, I think, is the term I heard you used earlier. So they do have that requirement. And the other reason is because different providers triage different tumor groups. And so in the same way we've demonstrated here, they have one location for all of their new oncology patients, but we need to be, and the medical service is the same, it's medical oncology or radiation oncology, and we needed one more level of granularity for them, so that only the appropriate providers would be looking at the appropriate referrals. So what you're asking for is essentially the same as what we provided for them. The difference was that they already had in their system established tumor groups. So in their operation, it's already part of the way that they keep track of their patients and report. Whereas what you're asking for now, like some other level of subspecialty, would need to be designed from the ground up, and it's pretty significant. We would have to work with the enterprise on it, and so that's going to eat into a lot of time.
I'm just sort of thinking, and like with all due respect to sort of the process that happens for every clinic, but like I think this is going to eat up a huge amount of time for every individual clinic design, because this issue keeps coming up in 5 different clinics that I'm running, and it's like if we can just solve it now, I feel like it's going to save umpteenth hours of SME time, like when you unroll 90 clinics with no sort of great solution for this. Because I think like either option of what I'm kind of hearing is not ideal. It's either that we actually build out the locations properly with all the granularity that we actually need, or we do this kind of workaround thing, which I got to say, like having done this with Cerner before, every time we do a workaround, it comes back to bite us in the ass 5 years down the road when that workaround has some other problem. So like I'm not wildly enthusiastic about that idea. I doubt that data is going to be very robust. And so I'm just sort of like strongly advocating to have this bigger discussion now so that we can save ourselves a lot of headache when we unroll all the other clinics.
Yep, totally agree with you there.
So what would be the best sort of way to have that discussion?
So I think what I'd like from you right now, Dr. Yang, is, and Susan, I think I'd like to know if you agree with the statement, which is that if we can sort out your triage, which in the same time will somehow add some differentiator to the encounter. So if we can figure out how to add one more level of granularity to the encounter, you would like to have one location for respirology. I think that's what I'm looking for right now, and I know we're at time here. And then bring that requirement for one more level of granularity without building out, 4 more locations. And opening that can of worms for your other clinics with subspecialties. If we can get that next level of granularity, then we'll look at that at a site and enterprise level. Does that sound reasonable?
I think that sounds like a great solution. I know we're at time too. I just want to make sure though, Kat, I'm understanding you're talking about sort of another field or area like the tumor group area where we could actually have this detail that we need.
Yeah, and I'm thinking of something generic as well, like the triage priority field. We had to make that as generic as possible so it would suit everybody's needs. And I'm just thinking that we could make something that is, and please don't hold me to this because I'm just making this up now and I've talked to nobody about it.
Yes, I'm very surprised.
Yeah.
I guess the only other thing I'd say about that is like the mapping coding idea is going to be way too messy, like a 1 equals this kind of idea, or a free text. So I know that now I'm putting on stipulations for something you don't even have, Kat, but I think it does have to be done well, I guess is my point, because otherwise we're going to end up again with workarounds that ends up not really helping the situation. So on that note, I'm so sorry I have to go because I'm chairing the next meeting, but I really, really can't thank you guys enough because this has helped a lot with my understanding, and I appreciate, Connie, your thoughts, because I do think this is something we need to tackle quite quickly at the sort of site level. So thank you all.
Yeah, I want to also thank you very much for the information in this conversation. I would wanted to offer that if we are thinking about that another layer of, I guess, self-service, I'm more than happy to I guess be part of that conversation to make sure that in terms of reporting that is helpful for us. Thank you very much.
And so I think we've derailed a little bit this, probably the intent of some of this session, but I guess from the CST and our clinics in particular, was there stuff we didn't cover that that you guys wanted to cover? And do you want to try and use an hour this afternoon to do that, or were we pretty much done?
So we are just done with the co-location discussion, and the afternoon session which we combined in this session is like we haven't discussed yet. So there are some points which we need to review with you. So would you like to continue right now? I know some of our team members have another meetings too. So
we can also look to see what's remaining and try to follow up by email if it's not too difficult.
Yeah, so I can quickly go through the presentation and we can touch the points.
Okay.
Yeah, thank you, Kat.
I'm happy if you want to sort of finish off your presentation just so you can sort of get through it and let me know what design decisions need to be made.
Yeah.
I can do that now, or I can do it before or after this afternoon's meeting for half an hour. Whatever works easier for you guys.
Yeah, sure. So if we can go through this, if you have 15-20 minutes.
Sure. Yeah, let's do it.
Thank you. So for internal referral order, we are all like April is also already communicating with you via email on internal referral order, which we are building. Like we'll have reference note that contains information how to refer to clinic. So April, do you want to comment on this, or you want to ask?
No, I just want to say, Dr. Yang, just whenever you can get that information back to me, that would be great.
Okay, and then I think there's probably a side discussion here, which is like the whole, do we do templates? Is that sort of the enterprise solution for our current referral forms? Is that we're going to have templates for all of the various clinics at Children's that need specific granular detail?
Yes, that's our enterprise solution for the clinics that have an internal referral so complicated that you need to make your referring providers fill it in step by step. Yes, that's what we can do.
Okay, and then I presume in that reference note to clinic that you guys are wanting from me, I think this was my question, can we actually put the shorthand note for that in this reference note to clinic, like comma, BCCH, referral, asthma, or whatever?
I don't see why not.
Okay, sounds good. So I think I need to have a bit of a think about this, April, and figure out how we're going to divide all of this up and which clinics actually need these very specific referral forms and which don't. So I will get back to you.
Thank you.
Thanks, Dr. Yang. So we already discussed on page, and I see Nico is going to drop, but we wanted him to answer on the work queue monitor queue with you.
Right, is that the fax numbers business?
Yeah. So Nico, are you here or you already dropped off?
Suk, I think he might have dropped off.
Okay, so then
That's okay. He sort of talked to me about it, and I think he was waiting for me, and I was waiting to ask you guys a few questions about this.
Okay, sounds good. So next is our referral triage and follow-up power plan. Doris is already sharing it with you via email, and we need to verify the list of orders within power plan. So if we have Doris here.
So I will just say from my end, this is entirely dependent on this conversation that's happening with Nico about whether we can or cannot have clerks booking spirometry, etc., automatically. Because if that's the case, that saves a lot of our workload on the physician end and changes what this power plan looks like.
Yeah.
So do you know? So I'm guessing that's a decision that's going to be sorted out in the next few weeks.
Okay. Yeah.
Sorry, I'm just asking a question. That's not a comment. Yes. Okay. So I think maybe if Doris or somebody can circle back to me once somebody decides with clerical what they're allowed to book without us making a note, then I'm happy to finalize those power plans.
Okay, so we have Jacob and Doris here, right? So they will follow up with Nico on this. And Next is our work queue monitor queue and sorting. So we need to know like how many queues each clinic will need on work queue monitor, and need to know about the communication convention, naming convention. So I guess I would request Pamela to go through this from scheduling. Pamela, you there?
Okay, thank you. Yes, I can hear. Sorry, I was on mute. I would share my screen now.
Okay.
Let me know when you can see my screen.
Yeah, it's loading.
Okay.
Yeah, we see it now.
Okay, so based on previous discussions and TSA recommendations that each clinic will have 2 queues, where one queue will receive all fax items linked to the fax machine, and clerks will have to sort through the documents received in the queue and reroute to other queue. I wish Nico was here so that I can he can be part of the demo because we had this discussion last week. So an example is SPH pre-heart treatment clinic. They have 2 queues. They have one for results, they have for referral. So based on this, if we say, okay, let's assume this is asthma, maybe we call it asthma gen, or because I just got to know that we have for the naming convention we have character limits. So a total of all the queues should be below 1,000 characters. So when when choosing the naming convention, we have to be careful about the naming convention. So let's assume this is asthma clinic. We have referrals, we have a document here, and we have different, we have a second queue. This is maybe call it gen, and this is referral. So what we if Nico is the clerk or somebody else is the one sorting through all the documents, the fax received every day, what he does is to just go here. I'm like, okay, this is a referral, and just reroutes it to referral.
Can I just clarify? Sorry.
Okay.
In that where you were before, so that queue, is that tied? Each of those is one fax number, or?
Yes, one fax number. The one is one fax number. The second is not tied to a fax. So,
I see.
If this, for example, is BCH asthma gen for all asthma referrals, reports, and all documents that comes in, and the clerk goes through it every day. It is tied to like a fax machine. So the clerk would just look at it. Okay, this is a referral. Then, asthma referral. Then choose the routing, then select routes.
And so just to be clear, so what you needed from Nico and from me, I guess, is one is sort of like how many fax numbers are we actually going to use? And then the second question is how many of these various tabs do we need to properly sort things so that they can get to the next stage of their life?
Yes. And so can you share the screen? I have some recommendations. So
sure.
The decision is based on what you decide, knowing that May 1st is the deadline for both the naming convention, the fax, and all that. So.
And out of curiosity, from a naming convention, is this like searchable to other people in the hospital? Like it needs to make sense to them, or it doesn't matter?
It has to make sense.
Okay, gotcha.
Yeah. So I just came up, like this can be a direction for yourself and Nicole when you decide what is going to be based on the information gathered. BCH asthma can be general or gen, and this is the fax line. Then this is the second queue for the referrals. For CF, the same thing, referrals. Then for RESP, HCV, sleep, that they share one fax line. All the documents will come into one, this queue, and then the clerk will route it to RESP general, referrals, HCV referrals, sleep, and PF lab report. So yeah, that's
Gotcha.
So I can send a copy of that, of this slide to you, so that when you're making the decision, you can be a basis for direction. Yeah.
So I think the two questions we had, because the clerical staff and Nico are sort of thinking we just actually have one fax number, because the workflow is going to be one clerk is just going to sort through all of the faxes that come in.
Okay.
If we sort of go that route, then the question is what happens like on go live date to all of the faxes that are going to our other two numbers? Is there like a cut over where it'll get forwarded for a certain period of time? Because for sure, people have our fax numbers all over the place.
I think I'll have to circle back with HIM so that I'll get the information on what happens with the fax number during cutover activities.
Yeah, it's just Brenda here. We would have to sort of find out if there is a plan like that. I know in the past what some clinics have done, of course, and again, it's just some information like they've sent out, communication or updated their website with, new numbers. And then I'm not sure if if the clerks would have to then just scan that in themselves. So if they do get it on that paper, or the wrong one, would they just scan it into themselves and work you?
Okay, so yeah, maybe if you guys can let me, I mean, that may not affect the decision in the long term, but from a safety perspective, we'd probably just need to know where those things are going or what you guys recommend, because maybe in an ideal world it still gets put into a work queue monitor for 6 months, a year, or whatever, and we just sort through them. But yeah, maybe you guys can get back to me about what you guys would sort of recommend. And then can I just understand how those work queue monitors, or is this completely unrelated to that other triaging piece that we were doing? Like if we decide we're going to have 10 different triage lists, should those be 10 different queues in this work queue monitor, or what's the difference between those two things?
For the work queue monitor is basically for external referrals. When external referrals come in and you attach to an encounter and send to the provider for triage. So there's no triaging list based on work queue monitor. Yeah.
And so with the decision to have sort of various different tabs on that page, because like potentially a different clerk, for example, for CF would be responsible for tagging that into something to push it into our actual clinical system. Is that sort of the rationale for having multiple versus just one giant tab?
If you have one, that would be like a lot of workload for the clerk. Like that means CF, HTV, RESP, asthma is just coming into one, and then the clerk sorts and puts it to the different queues for the different clinic. But what we were thinking, we were leaning towards the for each clinic having 2 queues, one for normal, like one for everything, then the one clerk comes and pushes the documents to the second queue, which is basically for referral. So if you're saying you just want one queue for with one fax number for all the different clinics, then it's something we can explore as well.
I guess probably Miko and myself don't entirely understand, because this is what he was asking me and I don't know, so let's just say we use essentially work queue monitor is just sort of like the giant pile of faxes that come in. And so like in the real world, those would get sorted into mailboxes and we would deal with them. In my head, the mailboxes exist on our clinical system, not on this work queue monitor. but it looks like there's another kind of way to use the system, which is you create all those mailboxes, for lack of a better term, within Work Queue Monitor. And I'm just trying to understand, like, what's the difference and why would we decide one versus the other?
Okay, so because based on the information gathered, you have 3 fax machines, right? For CF, asthma, and rest general, right? So based on that information, we decided, okay, since we will have, the 3 different queues based on the fax number, then that is why we will have the 3 different queues. But if you're saying, okay, going forward, you want it to be respirology, BCH respirology, then it's something that can be done as well. All the facts for the 4 different clinics piles up into that one queue, then it's now sorted, to other queues. But the challenge also is what happens to non-referrals. That means it will stay in just one queue. Like we're thinking, okay, asthma has, reports and the different document referrals, then they have asthma referral, and the asthma referral queue stays in asthma referral queue. Then the other documents for asthma is in, the other queue, which has been routed. Then for CF, like, it's more organized that way. But if, like I said, if the decision is just one queue for all the clinics, then we can do that as well.
Yeah, I guess what I don't understand is, so let's just say we go with the decision that we're going to have one fax number, which will essentially be like generic everything. What is the benefit to having multiple tabs in Work Queue Monitor? So for sure, one clerk is going to have to sort through all of these various documents and put them into the right homes. It's like, I guess I don't understand, like, putting them into the right home within Work Queue Monitor versus putting them into the right home within CST Cerner. Like, is it just there's a different, that's the part I don't understand.
Okay, so I remember.
Hey, it's Kat. I'm going to jump in here to try and answer Dr. Yang's question. Dr. Yang, if you have one person who's receiving the incoming fire hose of faxes, but maybe you have different people who are going to work on those incoming documents in some way, then it's beneficial to move them to another list so that it's a lot easier for the second person. It doesn't sound like your clinic's workflow. Another thing that's nice to have is a list of referrals that are incomplete. So a list where the clerks have already contacted the physician and asked them for more information, or maybe you've asked the clerk to contact the physician and ask them for more information. And otherwise, and then the other thing is you guys get a lot of faxes that are not referrals. And so what are you going to do with those? I don't know if we have an answer for that yet. But no matter what happens, those should probably also go to another list of documents. We're not sure yet if we're going to attach to the chart or not. Or, we got this document, we don't even have the patient yet. So that kind of like bucket of this isn't a referral, we don't know what we're going to do with it.
And I guess the sort of concept of, like, if somebody else wants to work, quote unquote, work on this document, like, what is the work that happens at this stage of the game versus it gets pushed into sort of like the actual patient's chart? Like, is that complicated? Is that sort of a fair bit of work, or is it just like, yeah, that's the part I don't quite get.
I just want to make sure I understand your question. How complicated is it for a clerk to just receive let's say a non-referral document? So
test result,
additional test result or something. It's not very hard at all for them to add it to the chart. I think that you wouldn't need an additional queue for that. They could just go ahead and do it. But if they receive something that they don't know what to do with, it can be helpful for them to have another list to put it on.
Okay. And I guess part of it is, like, I can sort of get why we'd have various different clinic sort of within Work Queue Monitor for the different clerks to work on. But if the workflow is actually, like, in my head, it's a referral, and so from referral and Work Queue Monitor to get pushed into the system to have like I don't even know what it's called, a triage encounter type or something. Is that fairly easy, or is actually the workflow you pop that into 5 different clinic sort of triage or referral lists?
I don't think for your clinics that's necessary. I think that if you have one location or 5, it doesn't matter. I think that the clerk should be able to sit there, pick off the complete referrals, create the referral encounter, dump them on your triage list, attach the documents, and move on.
Great.
It's where they find referral documents that are not filled in completely, then they're like, uh-oh. So if that happens a lot at your clinic, what you don't want is documents that nobody knows what to do with right now clogging up your incoming queue, because it makes it hard for the clerks to know, what am I supposed to do next? Am I supposed to do that one? Oh no, that's been sitting there since yesterday. Why is that sitting there? It makes it a lot clearer if it's moved to a list that's called like waiting for additional stuff. Or move it to a list that's called waiting for Dr. Yang to tell us what to do with this document.
Okay. And if it's sort of like the sort of idea of potentially separating out into various clinics is like, if we have an unclear document, but it's clear that that's a CF referral that's incomplete, we dump that onto a CF, awaiting information. The sort of rationale for that is like, we actually have a different clerk that's going to deal with that tab versus the other tab. If it's actually one clerk that deals with all incomplete documents, we could just have like a incoming and then waiting for more information tab or something.
Yep, you got it.
Okay, gotcha. Thanks. And then
Pamela, did I tell any wrong things?
No, is everything more perfect?
Okay, good.
Yeah.
Good.
And then can I just clarify, so what is the physician sort of, because we do get a lot of documents that people don't know what to do with. So like, am I supposed to go into work queue monitor to like, or the clerk's supposed to print out an incomplete thing? Like, what's that communication look like?
You do not have access to work queue monitor, right? Other people on the call? Pamela?
Yes.
No.
Yes, she doesn't. No, she doesn't have. But from my discussion with Casman, she said it depends on the position we decide to give. So if Dr. Yang says she wants access to working monitor, maybe just a view of something, that's something they can explore.
Oh, okay. No. So I don't necessarily want the access, but what's the enterprise workflow for like, clerk doesn't know what to do with document on work queue monitor, and then what's the next step?
I think this is one of our bad workflows, right, Brenda?
Yeah, I was going to say, I think it depends on what exactly happens in the clinic. So we looked into this particular instance, and you'll see some clinics actually have a role, what they call a screener, which is usually a nurse who kind of goes through everything and sort of decides what needs to be sort of put where. If I'm not...
Can I just ask a question? If that's the scenario, then is the nurse going on to work queue monitor and they look at this incomplete list, or?
So no, what happens is they generally look at everything that's put in. And so some clinics have like a clerk who knows, like, if this patient needs a referral, they need A, B, C. They are the ones who make it incomplete, and it lives on their list, and they reach out to the referring provider. Other clinics don't have that, and their clerks will just send everything to, either a nurse screener or the triager. They then look through everything, say like, this is missing, this is not missing. And then at that point, they can actually place an order. And this is where maybe, Connie, like, so say, for example, you get something for a clinic and you're like, oh, we really need this before I can make a decision. You actually can place an order to the clerk to say, this is incomplete, please, please get me, reports ABC. And then that sort of lives as an order that you'd be able to kind of follow through.
Yeah, but I still don't really understand how things are jumping from work queue monitor to my triage list. So a clerk has a referral. It's either going to be a referral. So let me just walk through 2 scenarios and you guys tell me what makes the most sense. Clerk gets referral. They dump it into my asthma clinic referral list. I say, actually, this doesn't make any sense. Please get whatever. That document is living as a potential triage in Cerner CST. It's done in work queue monitor, like it's not in work queue monitor anymore. And then does it somehow get put back onto work queue monitor for the clerk to sort of follow up with that?
The document doesn't get put back onto work queue monitor. At that point, the document's in the chart. What you're doing when you ask for more information is you're changing the referral status of the encounter. When it's on your list, it's ready for triage. And when you ask for more information, the status of that changes to, I think, like
pending.
Pending. And it goes back to the clerk's list and it says pending. And then the clerk's like, oh, I got to deal with that one. And they go and look to see what you said and then follow up with the doctor. So I think when it's a referral, it's pretty straightforward. What I'm less clear on is everything else that you receive. If your clerk is able to look at everything else and know if they should attach it to the chart or not, or what do they do with all that other stuff?
Yeah, and my understanding from some busier clinics, I reached out, say, for example, to SPH Cardiology, their informatics, because I said this has to be an issue elsewhere, but they generally have a different role in their clinic called a nurse screener. So the clerk puts everything into the system, and it's the nurse screener who kind of goes through everything and takes a look.
But like, okay, so let's just say many of the clinics here will not have that. We just don't have enough nurses. So say 50% of what we get are referrals. The other 50% are like clinic notes from outside physician. You know, they probably need to be in the patient's chart, or it's just like, who the hell knows what this thing is? Maybe it's not even attached to a patient. So like, what is it? Or prescriptions. I guess like that's a huge other thing that we get is like refill prescription requests on the fax. So what are you guys recommending that workflow look like?
Another recommendation that we had is and again, it would take some time to sort of get out to the community, is having 2 fax numbers.
No, I understand that, but I think like, okay, so with the idea that really ideally, it's like the only thing that gets into WorkQ Monitor is actually the referrals. But like I will say, like a huge amount of stuff that comes through the fax machine should actually get filed into a patient chart. And if our clerks actually need to scan that and put it in, it's already scanned, that saves a step. So like, to me, the sort of process is, how do you get rid of all the crap that isn't a referral, that doesn't need to get filed in a patient chart? My guess is the work sort of flow for that is the clerk just prints it out and sticks it in my physical mailbox.
They can also print it out and send you a message in Message Center. They can, if they have a good idea that it should be in the chart, they can attach it to the chart, send you a message. Yeah, it's not great. That's why I said this is one of our bad workflows, because what the natural thing to do would be for them to take that document and attach it to a Message Center message and send it to you and say, what do you want me to do with this? But the system does not permit that.
Okay, and this is where I get like super nervous about clerks filing things without the provider knowing. So it's sort of like, it has to be baked in somehow that like, they can't just file something and nobody sees it or gets a message that something's been put into that chart. And so is that just, we don't have a good workflow for that?
No. No, we don't.
Okay.
So if I were you, I would almost try to get 2 fax machines going, where one is all the stuff that you would like to put in the chart, and the other one is for, as you say, prescription refill requests or whatever, anything that you don't want to have put in the chart. You'll definitely get some wrong things and some wrong cues, but eventually it should really cut down on your work of remediating those things. And then it's a lot easier to send those paper refill requests to you than it is for a clerk to have to print it out.
Yeah, I guess I'm still not entirely, let's just say in some magic place that I can actually make that happen. So say all of the stuff, you know, that's supposed to be in the patient chart actually gets directed to the right fax number.
Yeah.
But I'm still not clear how the clerk lets me know and attaches a document somehow that says like, hey, this letter came in, and then I do something with it and then tell them, yep, good to file.
So they have to send you a message. They can do that in Message Center, but the problem is that at that point the document is stuck in WorkQ Monitor and you can't see it unless they print it.
Is it possible for them to push that document into, like file it, I guess, into the patient's electronic chart and then send me a message saying this document's there? Like that would be the other workflow, I'm guessing?
Yep, absolutely.
Okay.
And they can send a message to you or to your provider Message Center pool at the clinic or whatever's most appropriate.
Okay, gotcha.
And then, Kat, can I just ask those? But then all that stuff would be part of that patient's EHR, because they can't take it out after.
No.
Yeah.
And so because I'm sure this is med clinics, but do you guys have a recommendation for what that looks like, or just let's figure out what works best for our clinic?
I think as Brenda said, we'll figure out what works best for you. Our recommendation is whatever's going to be the safest for you, and that varies greatly depending on the amount of autonomy your clerk has and the variety of stuff that's coming into your fax machine.
Okay, gotcha. Like, I think just we're probably leaning, because this is what the clerks think makes the most sense, is to have one fax number where everything comes in, which I wasn't super keen on because of that exact issue, but maybe we'll get back to you. So I think that's one thing we need to figure out. You guys can get back to me about what the heck happens to all the documents going to the other fax numbers. And then I think I need to talk to the clerks about the workflow of like that work queue monitor. Because in my head, actually very few things will live in that work queue monitor. Our clerks don't have a lot of autonomy to do that kind of stuff. In which case it may not necessarily help to have so many tabs. It'll be just sort of like stuff and stuff that needs some following up. Is my generic feel for it, but we can get back to you about that.
Okay, that sounds good.
Thank you.
Pamela, do you have any other questions?
Pamela, you here? So I guess if we don't have any questions on work queue monitor, then we can go ahead with the wait list. Jacob, do you want to present this?
Yep, I will share my screen just so I can show Dr. Yang exactly how this request list is going to look.
Wait list, not request list.
Or wait list, yes. I'm going to first show the future requests, just so I think we should have shown this during the location discussion. But so, can you guys see my screen?
Mm-hmm.
Okay, perfect. So this is the new request list by location. There is more filtering opportunities here. So we are in the process of getting this approved, where your clerks will be able to use this. It allows for you all to filter down by appointment type, which is something you guys had concerns about in the past. So these are all the future requests, and it is driven by location. So if you guys did consolidate down to however many locations into one, all those requests would flow here. So as you can see, patient name, requested date, priority, appointment location, and then right here is where we could differentiate by different orders. From here is when we were talking about earlier, where you can drop things into different buckets. So you can, say this is referral to asthma, we could go ahead and modify this request. And this is where we now can pick what bucket that this request is going to drop into. So usually your workflow would be from future requests to your triage list. And then after triage list, and once that triage gets accepted, we can pick the wait list. So here is a clinic, for example, that has multiple different wait lists. And so we could have a wait list for CF, asthma, general rest, and sleep. So that is definitely an option.
And can I just clarify, sorry, this page that you're on, how does this relate to, has this been triaged or it hasn't been triaged?
All stages will show up here.
Okay, so this is like the whole bucket of like random referrals that we sort of get. This is just like, boom, it shows up on this page. This is the clerks sort of looking at this to figure out which triage list to put it in?
Yeah, after you triage it, then this way it will look to the clerk. Yeah.
So these are all the internal requests too.
Yes.
So these are either your follow-up to clinic or your referral, your internal referrals will fall onto this future request queue. And then from here is when the clerk decides, and pretty much is, for a lack of a better term, is like their task list. They have to monitor this every day.
And where do the external referrals show up?
In work queue monitor.
But so okay, so once yeah, I guess this is where I don't really understand how these two systems connect.
So, and then, so they will, here, let me go. I'll show you. So when you get an external referral, you're going to type in the patient's name. I'll go through the whole process real quick. just to get a good understanding.
And Jacob, correct me if I'm wrong, and we can see that in referral management too, right? Under PM office.
Yes.
Okay, I'm just going to fill the rest of these out.
And this is an external referral that's coming in?
Yes, this is an external referral. So they will have pretty much going through the workflow of scheduling an appointment, and then you're going to move it to the work in progress field. And instead of scheduling it, so obviously they're going to have to go to a wait list, correct? So instead of hitting schedule or suggest, we're going to hit request. And now is when we can drop this appointment into whatever bucket is needed.
Okay, so that's an external referral, which essentially, okay, so they create the encounter, dump it into the waitlist bucket.
Yes.
Okay, and then, so that's when that thing shows up.
It's when it's already, the triage has already been accepted. So they will be able to monitor that in PM office.
Okay, and so if I sort of understand the pathway of a referral, it's, most of ours are external. So let's assume external referral gets put into work queue monitor. The clerk then dumps that, creates a whole thing in, is this CS like Cerner or this is PM office?
This is Chatbook, so this is the scheduling application.
Okay, so this isn't even like me as a provider, I'm still not seeing any of this. This is all sort of clerical workflow?
Yes.
Okay, gotcha. So piece of paper comes through work queue monitor, they assign it to a patient, and then they put it onto a triage list for me. I triage it in the system, like in Cerner?
Yes.
And then the way they actually book it is in scheduling book?
Yes, so you will accept the referral. On PM Office is a different application than this. They will have a referral management work list that they will see, okay, this patient got accepted. And so then that's when they go through this. So they see Test Alex got accepted. So now they're moving from scheduling Test Alex and putting him on the wait list now.
Okay, gotcha. And so the difference is that with an internal referral.
With an internal referral, so we'll go to the request list. So internal referral, so somebody from cardiology just referred to neurology, and they show up on this list. And so from here, you can now move it into different buckets.
But isn't the bucket, like, I haven't even triaged this internal referral yet.
Yep, so then that's when they were going to go to the triage list.
I see. Okay, gotcha.
So and then the clerk can also look at the triage list and see that all these patients are still on your triage list.
Gotcha.
And
okay.
then
I hear you.
And then they'll move to the wait list.
Okay, so if it's sort of like us in our usual clinic workflow, if it's like a follow-up to whatever clinic, it doesn't get waitlisted, it just gets thrown in the bucket of the wait list for a specific clinic, because they can do that. And then,
So exactly, so that will still flow to this future request list, doesn't need triage, and so they'll just modify the request and move it to whatever wait list is needed.
Gotcha. And this is sort of where you can get the granularity of the wait list.
Exactly. And we can customize those wait lists as well. Those are not location dependent.
And out of curiosity, just because I see this tumor group drop down, what happens if somebody selects a tumor group? Like what does that do?
Well, if they select it, then yeah, that probably won't be good, but the request list that you guys are going to be using won't have this tumor group on there.
Right. I'm sort of envisioning a future world where like the magic happens and we have some kind of like pediatric group or whatever that's called. Like in that world, if they selected the right clinic, then the difference is that when I get into my triage list, this has sort of been sorted out into lists for me, and then I could actually pull up, sorting by 2 fields, the right triage list. Is that how this works?
Yes, with the magic wand.
Okay,
That's how it would work.
Okay, gotcha. Okay, sounds good. And so this list here is the clerk's workflow for sorting out all the crap on the future request lists.
Yes, exactly.
Okay. Is there anything we need to decide here, or this is just like good for us to know?
It's just good for you to know. I already went over it with Nico, and Nico seemed happy with the functionality. It seemed like all of his workflows would work.
And so I guess once we figure out locations, then we probably need to let you guys know what the various wait lists are.
Mm-hmm. Yeah. And then we can go about designing how the waitlist should be organized.
Okay, awesome. Sounds good.
Okay, I guess I can present the rest of part now.
I'm just looking at the time sequence left. Can we
only
deal with any of this by email?
Yeah, only few 2-3 additional items. So which we had from like last design session. So Dr. Yang was interested to know if we can communicate referral status to the referring provider. So provider can communicate referral rejection and acceptance to referring provider in
We're
case
going to go over that in the afternoon meeting, Dr. Yang, with the ambulatory group.
Sounds good.
Okay, so I can skip that then.
Yeah, and this thing is about locations, the rerouting business.
Yeah, rerouting referrals to different clinics. So, Kat, do you want me to go through this?
I think we already did. It's pretty simple from the provider's perspective. And then if you choose one location, it's easy for the clerk. If you choose multiple locations, it's a lot of additional work for the clerk.
Okay.
Yeah, and how to request a referral for a patient for a different clinic during when provider triaging a referral.
Yep, and we can put most of your common re-referral or additional referral orders on your referral power plan, and then the rest will be taken care of with your quick orders or your favorites.
Yeah. Okay.
Yeah. So we'll get in touch with you via email for reviewing the items we had from referral triage session, like power plan, triage power plan, and reference note thing, and for work queue monitor too. So that's all we had for this session. And if something,
can I ask a question? Because Nico sort of gave me, I guess you guys are coming up with what gets sent to patients on their patient itinerary somewhere in this whole process, which I think used to be a manual send out. They would literally print out an itinerary and mail it. And so he wasn't clear, how is this happening in the new system?
I think that's another, I want to defer that one to the afternoon as well, because that's part of the question about how do we notify them when we receive the referral, how do we notify the physician or even the patient for their itinerary. Gotcha. And I think that we have some folks on the afternoon call who will be able to speak to all of that.
Gotcha. And then I guess the only other question on that wait list, so how does it work to sort of see the book by date? Like how do the clerks actually book off that wait list?
Okay,
or is that sort of TBD?
So we know that there's an issue, Dr. Yang, because we were all at that meeting, I think it was on Friday, where we looked at the order that we do have, which has the priority, which as you saw has options like ASAP or next available or 1 to 2 weeks or 2 to 4 weeks or whatever. We don't have a book by date field. And so the way the system works right now, you would have to enter that as a free text comment in the instructions to the clerk. And so the clerk can see it, but it's not sortable or extractable or anything like that. So we know that there's a little bit of a gap there, and I've highlighted that and sent that to a bunch of very smart people. And I hope that we'll address that this afternoon, but honestly, it's something that I just don't know if we have a solution for.
And I can sort of guess that some of the workaround based on those wait lists is like people have a wait list for 3 months, for 6 months. They actually just create 1,000 different work lists. Is that sort of an option you guys are recommending if we need that kind of functionality?
I haven't seen that in too many clinics, and I'll get the scheduling team to jump in. The example we showed you with the hereditary cancer program with their 6 lists, that's the most complex wait list build we've done because they have thousands of patients on their wait list. Can anyone else comment on what a normal clinic would do?
So here, let me share my screen real quick, and I will go through the what Nico and I were just kind of discussing informally what would work and like looking through the preferences. Let me know when you can see it.
Yep, we're good.
Okay, so this requested date here is timestamped when that accept referral order is placed or the follow-up order. So I know I'm on the feature request list, but it has the same functionality on the wait list as well. So you can filter by this requested date. So if you do want a patient just to pretty much be added to the line per se, we would utilize that next available appointment option for priority. And then if you wanted the patient to skip or be like a higher urgent patient or stat, that's when you can utilize the priority like within 1 week and 24 hours. That way Nico or any of the clerks can sort by priority and see like, hey, okay, even though this is requested date is later than these, I need to get these booked sooner. So it's just, I think the workaround now is utilizing this priority in a better fashion instead of having the provider have to guess and not know exactly how long the wait list is going to be. So they will just have to use that next available appointment for all the routine appointments pretty much, and then the urgent for when they need to skip the line.
I guess the problem with that is going to be we actually, so let's say for new referrals, we actually have triaging priorities. And the sort of reporting that we do is whether we're sort of meeting our triaging priorities. So there are some people we think can wait 6 months and some people that we think can't wait 6 months. So I'm just not clear. Yeah, like I think we could use that. So this is the priority that I set during triaging.
This is the priority that you set. What you're talking about triaging priority is more of an incoming, I think, for you to look at. That's how we think of it.
Okay, so I could set sort of priority within 3 months, 6 months, whatever that number actually is for me. And then I think the challenges our clerks have is you'll have literally like 1,000 that say book in 3 to 6 months, and they all came in at different times. So I'm guessing then you sort of go by requested date and then subsort by priority, like on 2 levels. Can you do that?
That's the thing is you cannot sort within 2 fields at the same time.
Right. And that's why this is a highly not functional wait list. Like, how does any other clinic work with this, or does everybody do the weird Excel spreadsheet workaround situation?
So other clinics, not CST. So when a provider is placing an order, there's a future date option, but right now that is set to do not display, or else that requested date would show up. So that's the problem.
Sorry, so there is a potential field we could use, but the triaging provider just has to put it in?
We decided not to use that field. The enterprise decided not to use that field, so we've suppressed it. But because it is a legitimate date-time format, it is sortable. And I wasn't there for the original decision on why we don't use that one, but I think that a lot of times the triaging provider doesn't know when we're booking. And so if they ask to book by the end of next week, but we're booked up through the end of next week, it means the clerk has to then follow up with the provider to see who to bump. Whereas if you give the clerk more generic instructions, then the clerk can just go through their booking. But as you saw with the hereditary cancer lists, you're absolutely right, because you can only sort by one field at a time here. Hereditary cancer felt the need to make a bunch of wait lists so that they just look at the requested date within that wait list. So they can just do that single sort and arrive at the list that they need to go about their work. But what was just described here is exactly the problem, which is that the clerks have to choose which sort is going to be the best one and then visually scan for the other item.
Right, and I guess the problem that I can envision with having multiple sort of wait lists is that somebody's got to manually, like what was a 3-month wait list 6 months ago, then they just manually move them from wait list to wait list if they're not booking in those times?
So I think the idea is the 3-month wait list is this patient should not wait more than 3 months for their appointment. So it's kind of an urgency list. and then they go into that list and see what the next requested date is, and then they would book that person who's come up next. And then they're able to see, has anyone been waiting for more than 3 months? Then we're, we've got to do something about this.
Okay, so it's sort of like they get rid of this priority column, which doesn't really help for them. And then instead of having that column, their solution is you divide that up into multiple wait lists.
Yep.
Okay.
Based on clinical priority, basically.
Right.
Yeah.
And so Connie, it's just Brenda here. And the reason it works for hereditary cancer is they have one person just doing all that work. So it becomes a little bit more complicated when you have multiple people managing wait lists, but when it's sort of one role or one group, it becomes a little bit easier.
And I'm hoping that depending on your clinic, anything that comes through as urgent or within 24 hours or something like that would be booked right away. So it does actually simplify what the clerks would be looking at. So I think we just need to consider what your realistic list of, the task list for the clerk, what is realistically going to be on there, and what's the best way we can support the clerk with their work.
Yeah, so I'm sort of thinking, so what the clerk's wish list is just you sort this and it sort of runs down by when they should be booked. And then to be honest, like the vast majority of patients are well over our triaging standards. So that's why it sort of that's not so useful for them. What they sort of need is like, it's essentially requested date plus priority equals book by date. And they sort by that and then they just start booking. In the absence of that kind of functionality, any other thoughts?
That's something we'll have to take up this afternoon because you're not the only one. And I think you heard Dr. Gagnon say also the importance of this for maternal fetal medicine. Because the appointments have to happen at a specific gestational age, and the system doesn't really help them with that.
In which case, I guess then I probably don't need to make any decisions because hopefully there's sort of a bigger solution that we can utilize. Is that fair?
I don't know if we're going to be able to come up with anything better. So if I were you, I'd just start thinking about it and talking about it with Nico, but you don't need to make any decisions right now.
Okay, and are there only sort of options, either we just start creating lots of various wait lists, 3 months, 6 months, or the standard, which is this? Or is there some other option I'm not?
I would think of only those two right now in case we can come up with anything better for you.
Okay, gotcha. Sounds good. And right now, potentially, we're thinking about if we actually do have one location, this is one giant wait list or list.
Yep.
Okay. Sounds good. Is that sort of?
They can filter by appointment type, though. I think I heard, Jacob, you're working on that functionality.
Yes, and it's pretty much guaranteed that it will be approved. It's just going through the process right now.
So it's still one list, but there's ways to filter it down.
Mm-hmm.
Okay.
But the wait list, we can create different wait lists for CF and asthma. That we can have that not be location dependent.
Right. Okay, so this list could be sort of, is it this list or is it the next list?
It's the next list. This one we're looking at here is the to-do.
Gotcha.
And then once we're through with the to-do, then we move it to whatever wait list we want.
Okay.
Or we book it. Those are our options.
And then for the clerk to know what they're supposed to do, is that, as the triaging provider, let's just say we go with this idea of we're one location, is it within there that I would specify what kind of appointment type I need, like whatever, CF follow-up or CF new or whatever?
So ideally, the referral order that was written to bring it into the clinic for an internal referral is referral to CF, and so that's automatically associated with the CF new. You would tell the clerk if you wanted something different. Mm-hmm. And same with the follow-up. You write the follow-up order, and that's automatically associated to a follow-up appointment, and you just tell them if you would want something different.
Gotcha.
For the external referrals, it's assumed that if it's a new patient, that they're going to book a new, and if you want something different, you have to tell them.
And then how do they know which of those new, like if it's an external referral, whether it's a new CF, sleep, asthma, whatnot?
You would have to, I think you'd have to tell them.
And in the system, how do I tell them that?
There's spaces for you to write free text.
Mm-hmm. Special instructions that will flow over.
Okay, and I'm just sort of thinking though, so a clerk's looking at this ginormous list that potentially if we have one location, it requires, and I see it on that column, it says special instructions. So they would scan that list for the sort of providers typed in asthma, CF, whatever.
Mm-hmm. And if need be, you can, if it's too far away, they can scoot it up right next to the priority, just so it's more visible and they won't miss it.
Okay, and I guess, on the pro side of having multiple locations, then the referring provider doesn't do any of that. You actually just sort by location, and that does the sorting for you?
That's right.
Mm-hmm.
Okay, sounds good. And sort of out of curiosity, does this workflow work well for other clinics, like just relying on the physician to put the clinic type in the special instructions?
That's for your external referrals only. And
we get mostly external referrals. Like I suspect a lot of clinics at Children's get mostly external referrals.
Yeah, I think so. And what we would do then, Dr. Yang, is in your referral triage power plan, we would have that free text already configured in the order that you'll write. You'll write an accept referral asthma or an accept referral CF. And so even though that's free text, we can build what's called an order sentence so that you don't have to type it in every time. You just click a box.
Okay.
And then it grabs that for you.
Yeah. So yeah, exactly. It's just Brenda here. What Kat was saying is they'll do that with the order sentence and comments, and the PET team and PAT team will also work with you to during sort of personalization sessions, so you can have all that stuff sort of pre-populated. You have to enter it once, and then you can just save it as favorites and label it.
Right. And then I guess technically it doesn't make a huge, I was just sort of thinking this idea that you can't sort on 2 columns, but technically most things do not live on this list because they'll essentially go through this list, plop them into the right wait list, and then not really have to sort on this list again. Is that fair?
I think
that's fair.
Yeah, if we build your wait lists
separately.
Separately, yeah.
Okay. Because I would say that's just sort of from a locations perspective, a potential issue, but it sounds like that isn't actually so much of an issue because we're going to have sort of the whatever the work plans or whatever for people to use. Okay, sounds good. Yeah, anything else to think about?
Oh, many things, but give us 2 hours to think about it before the afternoon meeting.
Okay, sounds good. Thanks so much.
Thank you.
Thank you. And for our next steps, so we are hello. So yeah, we are waiting for confirmation of the dates for our next steps, and once I get confirmation from Mandy, I can send invites for design HTV design 2 and validation sessions, and we can figure out the pending items and review it on email. Yeah.
The home trach event is going to probably be a little bit delayed because we have to have some decisions go to governance group. So
okay,
we can talk about that soon. Yeah.
Isn't that one already booked or no? Or are we going to have to rebook that?
I don't have one in my calendar. Do we have that booked?
No, it's not booked yet, but I was getting confirmation from site, like availability of Dr. Yang and Dr. Wensley from admin clerk for the week of 10th.
Okay, if we can sort of, yeah, I think it might be delayed from that just because of some of the meetings we had regarding the documentation and the changes in design that needs to happen, needs to have some decisions made around it from our governance group. So I think it might be later. Maybe, Suk, we can meet for a little bit and kind of go over all that, and then Connie will send an email out. But my gut is telling me I think it's going to be delayed after the week of the 10th, but we could be hopeful.
Okay.
We just want to have something to truly show you versus and have that decision made versus, just bringing everyone back together to kind of talk about the same thing.
Yeah, and then I guess in terms of further design validation, I'm guessing a lot of this actually depends on maybe what's decided this afternoon for sort of site-wide solutions. Is there other stuff that does not depend on any of this that you guys need us to look at?
I'm not sure what's being discussed this afternoon. From an ambulatory perspective, I'd have to sort of talk with Sue to see sort of what things we need. The diagnostic perspective, for sure, I think we have some sessions booked coming up, so we'll still sort of proceed with those. Mm-hmm. But from our ambulatory team, the home trach event is one of them, and I'm not sure about I guess the others would just depend on what decisions are made this afternoon or more from a global sort of perspective.
Yeah, right.
Okay, in that case, because I think people are just getting a little bit confused about all the emails and requests for meetings. Maybe once you and Brenda chat, if you can just clarify with Dave and I and Mandy, sort of like, what is the session? What are we actually discussing? And then we can sort of just let people know who are the main allied health people that need to be there for those sessions. And then the full validation of all of our ambulatory clinics, as I said, you can invite everybody, but until we decide all of these things, there's no point to sort of probably have that validation session.
Yeah, definitely.
Yeah. Okay.
Yeah, we agree, Connie. We'd have to have all those decisions made and then have the last validation session.
Okay, sounds good.
Yeah.
Thanks, everybody.
Thank you, everyone. Yeah.
Bye.
Bye.